Madam President, we do have a quorum.
Wonderful. With that, I will carry on with the announcements. The date and location of the next Medical Services Board meeting is scheduled to be held Friday, February 13th, 2026, beginning at 9 a.m., virtually and in person at 303 East 17th Avenue, Suite 1100, Denver, Colorado, 80203. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar, and staff is ready to chat out instructions. Please identify yourself when speaking in the comments, as they are part of public record. Apologies. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input, in alignment with the department's mission and in the best interest of Coloradans. There is testimony sign up for the open forum and each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Public comment will be limited to 2 minutes today. At the end of 2 minutes, your time will be up and we will move on to the next individual signed up to testify. Thank you. And with that, I will take a motion to approve the minutes from our December meeting.
Madam Chair, this is James McLaughlin. I make such motion.
Good morning, Mr. McLaughlin. May I have a second, please?
Madam Chair, this is Cassie Littler. A second.
Thank you, ma'am. All in favor, please say aye. Aye. All opposed? Abstentions? Wonderful. Minutes have been approved. We are off to rules. The first rule on agenda is an emergency rule, document 12. We have robust testimony signed up for this team. This will be a very strict 2-minute public testimony rule. Also, we will be making sure that you stick to the testimony on this specific rule. This morning, we have Cassandra Keller up first to explain the rule to us. Good morning, Cassandra.
Good morning. Can you hear me okay?
I can indeed, ma'am. Go ahead.
All right. Well, good morning, Madam President and members of the Medical Services Board. My name is Cassandra Keller, and I am the Community Options Benefits Section Manager within the Office of Community Living. I'm here today to present proposed emergency rule revisions related to Individual Residential Services and Supports, or IRSS, and this is focused on the IRSS rate alignment adjustment. Individual Residential Services and Supports is a residential service offered through the Developmental Disabilities Waiver and serves approximately 8,500 members each year. IRSS is delivered across multiple residential settings, including host homes, family homes, member homes, and staff homes. While these settings differ meaningfully in staffing structure, operational complexity, and administrative oversight, current regulation has not clearly or consistently distinguished between them for billing and rate purposes, resulting in inconsistent billing practices and higher than anticipated expenditures. As I said, IRSS is delivered in a variety of these settings. As outlined in our rule, each setting type reflects different operational and administrative responsibilities, but we've identified billing practices resulting from this unclear definition and historic confusion about which settings qualify for this higher IRSS rate series. As described in the Governor's Executive Order dated October 31st of 2025, HCPF must implement strategies to ensure the long-term sustainability of the Medicaid program. Aligning the service definition and rates for IRSS is one component of a broader system-wide effort to manage increasing costs, promote equity, and support the financial stability of Medicaid while maintaining access to necessary supports. HCPF is clarifying definitions in regulation and billing manuals for IRSS settings to ensure the two series of rates are applied appropriately while also supporting savings necessary for program sustainability. The bundled residential habilitation service is paid as a daily per diem. These residential rates are tiered by the member's support level, with higher acuity levels receiving higher per diem payments. Separate rate lines exist for the setting in which the service is delivered, IRS and host homes and other IRSS settings, with distinctions between Denver and non-Denver rates. So it's a little complicated. We've seen a significant increase in expenditures for IRSS within this DD waiver. Average monthly participants has increased by 59%, and the overall expenditures have increased by 134%. The clarification we're trying to bring ensures that only staffed homes qualify for the higher IRSS rate, while host homes, family homes, and member homes appropriately bill at the lower rate. Staffed homes have higher operational and administrative costs due to provider overhead and management of the home utilizing rotating agency staff, which differs from the shared living settings where the caregiver resides in the home with the member. The intent is to ensure equitable reimbursement that reflects actual operational and administrative costs, promotes consistent billing practices, and supports the sustainability of the developmental disabilities waiver. While the department recognizes that some caregivers may experience reduced reimbursement depending on past billing practices and how they'll bill in the future, and the payment methodology of the provider, these changes are intended to create fairness and consistency across the program and follow several years of targeted investment in family caregivers, including an approximate 36% increase to IRSS rates over the past 5 years. Our hope is that 36% increase in the base wage requirements that are in place will help to sustain these providers and caregivers during this potential decrease. From a fiscal perspective, IRSS represents approximately $460 million in annual Medicaid expenditures, with a median cost of about $76,000 per member per year. The proposed rate alignment is projected to generate approximately $1.45 million in general fund savings in state fiscal years 25-26, directly supporting the sustainability of developmental disabilities waiver without reducing member access or benefits. The department has engaged extensively with stakeholders, including public meetings, other help meetings with specific stakeholders, and a formal comment process that generated more than 200 responses. Prior to hosting meetings, we were very clear and upfront and honest with stakeholders about what engagement would look like. We were clear that stakeholders would not be able to influence the executive order outlining this policy decision to align the rate methodology, but they could absolutely help craft this regulatory language. Over those multiple meetings, the department received, then carefully reviewed, and then incorporated suggestions from stakeholders. One example is changing the naming of the 2 settings types to be more person-centered and reflective of the living situation. These revisions are being brought forward for emergency adoption as a result of this executive order directing the department to promptly update the regulations so IRSS settings are clearly and accurately defined. It's critical that these definitions be in place this month, when case managers will begin developing new service plans and submitting prior authorization requests for members whose service plans start and are effective April 1st of 2026. If the rules were not effective immediately, service planning activities would move forward using outdated regulatory language, creating inconsistency and risk misalignment with the executive order. For that reason, the updated definitions must be adopted in rule and effective at this point when service planning begins. In closing, these revisions clarifying regulatory ambiguity, promote equitable reimbursement, and ensure compliance with executive order requirements, and they support the long-term Medicaid sustainability. We respectfully request the board's approval of this rate alignment emergency rule. And thank you, and I'm happy to answer any questions.
Thank you, Cassandra. Do I have any questions from the board?
Dr. Kennard here.
Go ahead, Dr. Kennard. Good morning.
Thank you for that, Cassandra. Our initial information provided in the rule was that there were 5,000 members under these categories, and I heard 8,500 from you. Just wanted to resolve that difference. And secondly, could you give us just an example? As I understand it, there's 2 basic settings, meaning a setting where a client lives with family and the family provides a substantial amount of care. That's one category. The other is a category where largely agency staff provide the bulk of the care. First of all, correct me if I'm wrong on that. And then secondly, could you give us an example, and maybe we're going to hear it from our commenters. So what's an example of a change that a family might undergo, and both hours wise and financially?
Sure. This is Cassandra Keller, and Laura, and for those in the room, it was a little hard to hear. The volume in the room is a little quiet. I've amped up my own speaker volume, so I may need to repeat part of the questions, but I did hear first about the number of members. So there's about 10,000 members on the developmental disabilities waiver overall. The majority of those individuals receive services through the IRSS benefit. Only about 3,000 folks or so are in group home settings. And so that's where the 8,500 comes in. Where folks reside, there's about two different, there's lots of different ways that they can receive services. But what we're trying to say is that if you live in a shared living environment, that is, you reside in the home of a family caregiver, you reside in the home of a host home, however that may be, that's a shared living environment. Anything else where you have rotating staff come in, that could even be a family caregiver, but if rotating a staff is coming into the home, that's called a staffed home. And previously we called out host homes as a billing type, and that's where the confusion has come in, is what host home is, and there's no call out for family caregiver. So what we're trying to make very clear is that family caregiver settings, where the family caregiver is the main provider, and host homes all fall under this category of shared living environment. I'm not sure I answered all of the components of your questions, so please let me know if I've missed something. Oh, I apologize. You asked where someone might experience a change. I think the issue where someone might experience a change is that their provider was billing as a host home under the higher rate. And so that provider would be, if this member is residing in what we're calling a shared living environment, they would need to shift to that lower reimbursement rate. It's still based on the member support level and at that level of service that they require, but that's where someone might experience a change, is how their provider is billing. The rates themselves are not changing. It is just how providers are billing for these two different categories.
Thank you, Cassandra. We're also working on getting the volume a little bit higher in the room. We had same issues, other people who were on remotely. Dr. Kennard, did that answer your question?
I'm okay for now. Thank you, Dr.
Great, and that's much better. Thank you, Kelly. You are just Superman. Do we have any other questions from the board? Hearing none. Mr. Sykes, I am aware of public testimony today. Is that correct?
This is Chris Sykes. We do have people signed up for public testimony, and we actually have a couple people in the room.
Wonderful. Would you mind handling all the technicalities on that?
Absolutely. First up, we have Nicole, who
Good morning.
traveled in the mountains to visit us.
Good morning, Nicole. Thank you so much for traveling to talk with us today. Kelly's going to put 2 minutes on the clock for your testimony, and you get started whenever you're ready.
Good morning, members of the board. My name is Nicole Villas. I am one of the family caregivers affected by this rate cut. My son, Aiden, is also
If
in.
you don't mind, you can start.
Okay.
I don't think it was something you heard.
Good morning, Madam Chair and members of the board. My name is Nicole Villas. I am one of the family caregivers affected by this rate cut. It is not an alignment, it is a cut. Then redefining family homes as host homes results in roughly a 10% cut to our children's care or adults' care over the next year. So I would like to address HCPUF's emergency rule change for this IRS living session. This should not be an emergency. It is not an emergency. It never has been. HCPUF has been trying to move forward with this IRSS rate cut, not alignment, for 18 months. They couldn't do it through the JBC last year, and so they pressured the governor to do it through executive order, and that's what has caused this emergency. It is a fictional emergency. First off, it's a rate cut, not an alignment. It's not an emergency. It cuts us down roughly 10% with the other cuts in the budget. This alone is about 8.1%. Family caregivers are not host homes. We never have been. It has not been confusing. There have not been confusing guidelines. HCPUF even issued a memo in May of last year, 25015, that noted that it family caregivers should have their providers billing at the higher rate. We are not host homes. We do not have other members with disabilities living in our homes. We are not able to combine other members and the funds that they come with to create a shared living environment. It is only one person living in our home that we are caring for 24/7. Secondly, their definition of a staffed home is fictional. A staffed home at the current rates cannot exist. You make about $9 an hour when you divide our care into 24-hour care that we provide. A staffed home at that rate is not legal. So them defining a staffed home in these new rules and regulations is just a way to cut all family caregivers, and it is all family caregivers, not just some, it is all of us, cutting us down to the lower rate. This rule change, should you vote to approve it, has real and unanalyzed impacts on adults with developmental disabilities. It will cut Aiden's direct life-saving care by nearly 10%. I am the only thing.
Thank you for sharing your testimony with us and for driving all that way. We surely appreciate your voice. Do I have a response from the department?
Sure. This is Cassandra. I really appreciate hearing from Nicole. The department has not only met with larger stakeholders, but our office director, Bonnie, and Colin Laughlin have met with Nicole and other families like her. We've responded to a white paper that Nicole and her colleagues have put together for us. I just want to reiterate, this is not, in fact, a rate cut. The rates themselves are not changing. It is how providers bill for the two sets of rates. Host homes and family caregivers are, while maybe not exactly the same individuals providing services, as one is related and the other is not, operationally, they are the same. And we don't call out family caregivers in any of our regulations as a special provider type. They are a individual who can provide care and provide services to our members. This is the same way we do it in long-term home health or some of our other home and community-based services. I think there was some confusion about HCPF trying to do this before. During our last legislative and budget session, we put forward rate options for the JBC to consider. It wasn't picked up at that time. However, now that the budget crisis has become increasingly severe, the JBC and the governor's office, the governor's office picked up this option and has asked us to move rapidly forward with this change in order to seek savings. So this was not something that we have been secretly trying to do for months, but something that we were ordered to do by our governor just a few months ago. I would contend that we have done extensive stakeholder engagement. This is not something that we are trying to do under the cover of darkness, but really trying to work with stakeholders to make sure that the change that we're required to do is done as effectively and appropriately with minimal impact to members as possible.
Thank you, Cassandra. Dr. Martin, I see your hand.
Yeah, this is Barry Martin. The presenter, the commenter in the room said that the family caregivers have only one member, where host home providers might have two or more persons receiving services in their home, giving them more income with fixed costs, and so it's easier for them. So one of my questions, or I guess my main question is, do we have any data on do most host homes have more than one person receiving services in their home? Or is it, do most have more than one, or is it mostly one?
This is Cassandra. Thank you, Dr. Martin. There's a lot of host homes that do have more than one individual. They also take various levels of individuals. So someone might have a host home provider may take one member with very complex medical needs, and so they only serve one, or perhaps they serve two members with lower behavioral needs. It all really depends. We also see a lot of family caregivers that have two children that are both on the DD waiver and they're providing services. So it's not exclusive that host home providers all serve more than one member and family caregivers only serve one. The other thing to call out is that we absolutely do see these staff settings. It's not a lie. It's not a made up fictional thing. providers provide services in these staffed homes where there's rotating staff. So that is an actual viable setting option that we see in practice today.
Thanks.
Thank you, Dr. Martin. Do I have any other questions from the board? Hearing none. Thank you for your testimony. Who is next signed up for public testimony, Mr. Sykes?
This is Chris Sykes. We have Britta Jimenez in the room with us.
Wonderful. Just as a point of order, we have lost all video to the room.
But we still have audio, yes? This is Chris
We have
Sykes.
audio, no video.
Okay.
Kelly is working on video.
Wonderful. Do we think this is something where we want to pause for a second, or do we want to carry on with testimony? And I just don't know what's involved with fixing the problem, right?
It would be a restart for this computer or I'm shifting over to this computer.
Can we continue on?
You can continue.
Madam President, Kelly has said we may continue on.
Wonderful. Please help me. Who is next for public testimony?
It will be Britta Jimenez.
Good morning, Britta. You have 2 minutes on the clock and we'd love to hear from you.
Wonderful. Thank you. Good morning, everyone. Being a CNA and IHSS caregiver is unlike any job in the world. You stand by your child as they go through things that a child should never have to go through. You have the privilege of knowing that your child is receiving the best care because it is you doing it. Putting a cap on your child's hours is almost a death sentence. Each child is individual and some need more than others. My child is 24 hours a day. Please consider putting a face to my child, Sabian. He is a living, breathing human being with rights and should be treated as one. Having adequate hours to pay covers all of the necessities that Medicaid won't cover, like braces, support pillows, hospital beds, special clothing, special diet ingredients, special lotions, adaptive living utility devices that make life livable for a person with disabilities, generators to make sure in case of an emergency your child doesn't stop breathing, maintenance and gas on your car to get back and forth because a breakdown is a life and death situation for a child with disabilities. Supporting your child as they go through daily epileptic seizures, making sure they don't fall out of the bed as they posture, having safeguards and bed
Excuse
rails.
me, Britta, I'm sorry. Are you in fact testifying on emergency rule number 12? Or are you in fact testifying on a different rule on agenda today?
I believe I'm between agenda 6 and 7 is what I was told.
Okay, this is document 12 that we're taking testimony on right now.
I was not informed.
I apologize. This is Chris Sykes. I apologize. Yeah, I
Wonderful.
dive bombed Britta over there in the gallery and we did not clarify.
Okay, so I have no problem holding my testimony until the appropriate moment during this meeting.
I so appreciate you, Britta. I apologize that I didn't catch it sooner.
That is,
You know,
I understand you guys are having some stuff going on today. No problem at all, Madam President.
the Zoom gods are taking issue with us today. All righty. All righty. Mr. Sykes, it looks like I am getting an update from the room. Are we still able to continue on with testimonies? Hello?
Madam President, can you hear us?
I can hear you.
Okay, Kelly has told us that he is restarting his computer and it will cut audio and cut video for a moment, but that moment is not now. So I suggest that we hold off until we find that moment. So that we don't cut anybody.
If that works for everybody in the room, that works just fine for me. I do see a hand raised in the gallery. I will please ask that someone from the support team reach out to Victoria Moole and see what we can do to assist her. And with that, if someone could please let me know who is up next for public testimony on emergency rule document 12.
So we need to take a break.
We need to draw ourselves out of the webinar.
Madam President, I have been instructed that we need to take a 5-minute recess so that Kelly can reset the audio and video.
Splendid. We are in recess for 5 minutes. Thank you for all you do, Kelly. We appreciate you. How are we looking, team? Can anybody hear me?
This is Barry. I can hear you.
Excellent. I bet Cassandra can hear me. All righty. We are coming up. It said, I got a little message here. It's always technology in the end. Isn't it cool that we've been Zooming this stuff for like 6 years now? And it's just every week, every day, every week, every month, it's something new. I'm so grateful that we have an IT team who does this for us. Room, do you hear me? Almost. Community, I see hands raising. The way that we handle public testimony in this medical services board is that you need to sign up with a link.
I'm the only individual that can ask to unmute.
Oh,
Okay.
I hear the room. Ooh, ooh, ooh.
I am walking with a microphone talking.
Yeah, you are. All right, so can the room hear me?
Yes. Madam President, yes, we can.
Wonderful. I'm going to address first the hands raised on the Zoom meeting. Order of operations for this meeting is that if you wish to sign up for public testimony, there is a link that will be provided in the chat. If you are looking for assistance other than how to sign up for public testimony, I'm going to ask one of the administrators working on this meeting with me to reach out with you directly, and then they will drop your hands. Does that make sense to Mr. Sykes? Does that make sense to you? I do not hear Mr. Sykes. Let's see. All right, I have just received another message that we are having issues in the room again, or still. Dr. Mulkey, I see your hand. Is that what you're reaching to me about?
Hi, Laura. That's not me. That's a different Christina.
Oh dear.
Yeah, I also saw that and I was like, oh, Christina spelled the same way. But yeah, I can hear
Right.
you, Laura. Us online people are good.
Okay.
But that's not me with my hand raised.
Awesome. Thank you for being you.
You're welcome. And it was nice to see you in Frisco a couple weeks ago.
Oh my gosh, the great coincidences of life are really what it's all about, isn't it?
Yes, ma'am.
So Christina, Barbara, and Victoria with your hands up. If you're raising your hands for IT issues other than not being able to hear the room, please leave them up and somebody from our support team will get back with you once we are reconnected with the room. If you are letting us know that you cannot hear the room, that's correct. Yeah, so that's kind of where we're sitting right now. I am kind of communicating with the room via text at the moment. It looks like they're trying to set up. They're still having issues in the room. They're setting up some alternate forms of communication. I think what I'm going to do is have us set in recess here for another couple of minutes. Again, if you folks are having technical issues, please leave your hands raised. If you have your hands raised to include testimony, please check back into the chat history, click on the link and sign up there. Thank you, team. anyone hanging out in the Zoom room wondering what's going on, we're having technical issues in the main room of our meeting today. Our IT team is working very hard on addressing the issue. And as soon as I get the okay from them, we will be restarting the meeting with public testimony on emergency rule document 9. Thank you for your patience. Christina and Shannon, I wanted to let you know I do still see your hands, and as soon as support staff is able to get back online, they'll be right with you to assist you. Again, thank you for your patience.
Blair, my son goes to school 20 minutes away in Davis.
Oh, that's.
Ooh.
For many years.
What,
Davis to be cool little place.
I'm sorry, Kelly, I'm gonna need you on this side.
I hear the room.
Okay.
We're getting close, I promise.
Yeah, no, I think that first, I thought we were about 30.
Oh, Cassandra, we can hear them and they can't hear
All
us.
right, that was cool. We gotta say, thanks to that and see the overnight shift today.
Hello?
During the school. Beginning of the semester.
Getting stupid.
Oh, yeah. It's been all winter. Yeah.
There's some stories with stupid things.
For folks in the room, if you have your,
Yeah, I gotta be honest.
Hello?
Stupid athletics. Yeah.
Where we all. I didn't know. I can't do that. I can never figure out how to make it not in.
No, not yet. Not anymore.
Ay. Ooh, this is good. Ooh, very good. Okay, this is looking good. All right, room, if you can hear me, we can see you, but you are on mute.
Okay.
You are
And there's
off
no
mute.
echo now. No, we're not muted anymore.
Laura, can you hear us?
I hear you. Do you hear me?
Yes.
Woo! All right. Go technology. I am going to take a moment to just say welcome back, everybody. You are on with the January 2026 meeting of the Medical Services Board. We have been on an extended recess due to technical difficulties, and we are back. First thing I would like to address are the 3 hands up in the room. Would someone On the support team, please reach out to Christina, Shannon, and Rachel and see what technical issues they are having. I did let them know in advance that raising hands was the way to let us know of technical issues, and that if they wanted to sign up for testimony, they needed to do that on the link already provided in comments. But if we could drop that again, that would probably be super helpful to the folks in the room. And let's see, so we were in the middle of document 12, which is an emergency rule, and we were in the middle of public testimony. Mr. Sykes, who is the next person up for public testimony?
This is Chris Sykes, and next up, sorry, Kelly is running back to his computer to enable Mr. Thomas Cunningham from Loving Life.
Good morning. Is he in the Zoom room or is he with you?
Hello, I'm in the Zoom room.
There you are. Good morning.
Hello, this Thomas. Sorry. Good morning.
No, thank you for being patient with us. That it's been yeah.
I'm experiencing myself over here a little bit, so thank you.
So let's blame it all on Zoom.
Yep, exactly.
All right, if we could give 2 minutes on the clock to Mr. Cunningham, please, and we are anxious to hear your testimony.
All right, so I just want to start off with saying that this is a cut, and the attempts to make this cut do predate the executive order. It was in the Joint Budget Committee documents last winter, so I just wanted a little housekeeping on that one. And then I wanted to say, as a POSSA manager for more than 8 years, I've worked with hundreds of case managers and indirectly with hundreds more case management agency support staff in developing the prior authorizations or service plans in order for an agency to even be able to bill at any of the residential rates. And there's never been any confusion in that time, going back to 2017 when I started, about family caregivers, individuals in a family caregiver setting are being billed at the IRS non-host home rate. Historically, the regs did differentiate family caregiver a little bit more so than now. There's still publications, though, that kind of indicate really what's been generally understood across the industry, and that's individuals on the DD waiver in residential services. There's 3 billing categories. There's group home, there's IRSS, and then there's IRSS host home. And the assumption is basically all of the individuals that aren't host home or group home are billed at the IRSS non-host home rate. I guess, for example, the current support level review form, that's collecting info on members that are trying to get their support level changed or reviewed. The residential setting options are host home, group home, 3-person IRSS, privately leased/owned home or apartment, or a family home. So again, there haven't really been the staffed language terminology quite as much used until this time.
Thank you, sir. Thank you, Tom. That's time. We really appreciate you. Do I have a response from the department?
Sure, this is Cassandra Keller. I can comment real quickly. I think where case managers perhaps may not have been confused in the same way, I think I would contend that we have always intended for the higher cost of service, those staffed settings are the ones that should be at the higher rate, and that host homes and family caregiver settings, those both of those residential settings are the same and should be at the same rate. And so that's where we're trying to create, is maybe folks weren't confused because they were billing where they thought they should, but the issue is that the intentionality behind the department's 2 rate was not being observed. And so we want to make it clear that host homes and family caregiving settings are the same, should be billed at the same, and that the higher cost of care in those staffed homes with rotating staff, that requires that higher reimbursement rate. And I just want to reiterate again the rates themselves are not changing. We are not reducing those rates through this action.
Thank you, Cassandra. Dr. Martin, I see your hand.
Thanks. This is Barry Martin. Colorado and many of its citizens have supported the idea of getting people out of institutional settings and more into home-like settings. It seems like these higher rates for a more institutional setting is kind of incentivizing the wrong setting. Where, you know, it's more beneficial to the providers to get people into group home settings, and that's, I think, not what most people would want.
If I may, this is Cassandra. Dr. Martin, those staff settings can't have more than 3 individuals in a home. IRSS is limited to those 3, so it's certainly not the same as a group home. It is community-based care, and really all we're trying to make sure we do is appropriately reimburse providers for the cost of care. I think these staff settings are far more actually infrequent than what you see as host homes and family caregivers. That's where the majority of folks reside. And so that's where we're seeing these costs shift, is that we have far fewer of these staff settings at this higher rate. The majority of folks are at these host homes and family caregivers. So I don't think we're inappropriately incentivizing what could be considered more institutional type of care.
Thanks.
Do I have any other questions from the board?
This is J.K. Costello, Madam
Good morning,
Chairperson.
Dr. Costello.
Hi. Cassandra, a couple quick questions. One, I've heard conflicting that there's not a cut, but I've heard families say there is a cut. I do see in the notes that this is expected to save $1 million. So that, can you reconcile those two statements, that it's not a cut and yet there will be savings?
Yeah, great. This is Cassandra. As we said, I just was saying, and we heard Mr. Cunningham say that folks who are family caregivers and do that type of setting, those have been historically done at that higher rate. Where we will see the savings is that those individuals are now going to shift to what is the host home rate, which is the shared living setting. So it's shifting those individuals from depending on the support level, it's anywhere from a few dollars to maybe $15. We're moving them from that higher rate to the lower rate. So that's where those savings come in. Those rates themselves are not changing, but where they bill is shifting to that lower rate where they provide very similar, if not equal, care to what's in a host home. And we're creating equity by reimbursing host home providers and family caregivers at the same rate.
Okay. Thank you, Madam Chairperson. One more.
Please.
That I get how you're saying it's not a cut, but I can also see how a affected family might see that as a cut if the rate is going down. And just a note, question. In the executive order, I know it stated that there would be a division of the host homes and the group homes. Sorry, I know group home is not the term. Does the executive order also state, well, there's no rate cut, so I guess that is not a question. But I guess I'm just wondering if $1 million, it's some money and it needs to be saved, but also this group of folks who could probably use support. That's all I have.
Did you wish to respond, Cassandra?
Sure. This is Cassandra, and I would say, absolutely, we want to acknowledge that this is not nothing happening to families. Unfortunately, this budget crisis is happening across the state. It's hitting every single service, from pregnancy care to applied behavioral therapy across the board. So we're trying to make cuts as minimally as possible, as small as we can. We're trying to sustain the program. As I mentioned, programmatic costs are continuing to increase. We have increased the rates year over year. We have a base wage and it's up that 36%. So I know this is going to be tough for folks, but that 10%, we're hoping that additional increases that we've done, there's enough of a cushion that folks will be okay. But everyone's going to feel these cuts, and it's really, really tough. And we're trying to do it with, we keep saying, a scalpel and not a hatchet, but everyone is unfortunately going to feel this.
Thanks. I heard you say cuts there twice, though.
So apologies. Broadly speaking, cuts to the Medicaid program overall is going to be tough for everyone. And not everyone is going to feel the impact of this. Providers may be billing at the appropriate rate and they don't need to shift. So some families may experience zero changes. Others may see a change in what their take-home pay is. That's absolutely possible.
Okay, thank you.
Hi, this is Laura Carroll. Here's where my concern lies with this being an emergency rule. And after hearing some of the testimony, emergency rule means it comes into place immediately. It sounds like there are an awful lot of families who are going to see a pretty drastic change to the amount of money that they are going to receive than what they are accustomed to in a very short and quick manner. I can only speak for my fixed income family, but any change to my income on short order and notice without proper time to adjust, ebb, and weave can be nightmarish. And so for myself, my concern with voting this in as an emergency rule is that we are not doing best by our community and giving them the appropriate amount of time to adjust for a major change that we are about to make. So this as an emergency rule for me is starting to become a little difficult to say yes to. And I would love to hear Cassandra speak to how it is we're going to support these families when we make a major cut in their payment overnight.
Absolutely, Madam President. And I can really appreciate that concern. While the change would take effect immediately, putting these new definitions in the regulations effective today, case managers are not applying, the billing practices, I should say, would not start any date before April 1st. And so what happens is the case manager is going to begin the practice. They work 60 to 90 days backwards, and they begin developing service plans here shortly for effective dates of April 1st forward. So that means they're going to start developing service plans that don't start until April. So families are getting warned now. These are the changes that might be taking place so that they can prepare for those that start April 1st. That doesn't mean every single person is having this change happen on April 1st. Instead, we're doing this on a rolling basis. So every month when someone has what we call their continued stay review and they redo their prior authorization and their level of care, that's when they're going to have this change. So it's going to be going month to month, and everybody will have this done by the end of November. So all of these budget initiatives are being done on a rolling basis and not happening to everybody the second the emergency rule passes, nor even on April 1st. But this just allows our case managers to start that preparation of the PAR and the service plan so that they can have them effective when their PAR does in fact start. I hope that alleviates those concerns, Madam President, at least to a certain extent.
It does, but it completely confuses me as to why we are then bringing this as an emergency rule. So I still am just
Good question. So the reason the reason we need it effective today is that case managers, when they're completing their service planning, so some of them are actually starting this planning process today, they need those definitions in place so that they can properly put members into those settings based on those definitions. If they're not in place, they would be putting them based on the current definitions that are not in alignment with this rate strategy. So they would be working off of the current definitions, not the items that we need for alignment. And so we just want these in place for case managers so that they can do their pre-work and be ready for April 1st.
I hear you, and I don't feel that as a reason for emergency either. I plan for next year's budget numbers all the time in all of the other work that I do. Just so you're aware, I am really uncomfortable with this being an emergency rule, and that's where I'm lying. And so I wanted to give you opportunity to hear how I felt about that. Cassandra, I appreciate your time. I know I have multiple hands up. I know I have multiple hands up in the room. First up in the room, I believe I have James McLaughlin.
Madam Chair, I I defer.
Madam President, we have both Adela and Rachel with their hands up that might be able to shed a little light.
That sounds lovely. Please do.
Okay, thanks. This is Adela Flores Brennan, Director at Healthcare Policy and Financing. So, one of the things I wanted to try and set up early in the meeting, but now's the opportunity. You know, we have had to deal with, I know we've talked to you all a lot about this, the $1.2 billion hit to the budget that happened immediately on the passage of HR 1. So we have had to quickly move to make a lot of adjustments and to recognize those savings so that we can balance the budget. Some of these things are coming through the subsequent executive orders. There was legislation passed during the special session in August that granted authority for the executive branch to make some changes. And there have been 2 executive orders since then because they only last for 90 days. So they've had to extend them. Those executive orders have directed us to make changes that are going to recognize savings that help us balance the budget. HCPF, given that we are taking up over 30% of the state budget, a lot of onus has been placed on healthcare policy and financing and Medicaid, whether right or wrong, to help reduce the expenditures in the budget. So as of now, between the executive orders and our November budget and supplementals, we have had to cut or propose cuts of $800 million to our budget. We are trying to do that in ways that both recognize that there are places that are increasing at a much quicker rate than we can sustain. There are places that we are, as Cassandra said, trying to use a scalpel rather than a hatchet. That said, it is never going to be easy to make these changes that result in provider rate cuts, service rate cuts, but we are trying to minimize the impact to the extent possible. So it is urgent that we pass these things so that we can have the regulations in place that reflect the changes that we are making in policy and practice.
And if I could just, Madam President, this is Rachel Entrick, and if I could just add to what our Medicaid director just said.
Yes, please.
Thank you. I think there are a couple of dynamics also happening that I know we talk about slightly less in this context. So we had a $1 billion shortfall at the beginning of this fiscal year already. Then we had the additional $1.2 billion shortfall that our Medicaid director just talked about, which is gigantic for us, right? I think the 2 things that we always have to keep in mind, not only that Medicaid represents 1/3 of the state's money that is available to spend, which means that there are 2/3 left over for everything else: schools, roads, childcare, everything you can imagine that it takes to run a state. I think the other thing that's very difficult here is we're the only state in the country with a Tabor amendment that fixes the rate at which we can keep tax dollars. So we do end up returning tax money to taxpayers on the basis of our state constitution, even if we have a shortfall, because we may have collected more state taxes than we are able to keep. So I think that's one of the other big difficulties. And the final big difficulty that I do just want to acknowledge is we are required, state Colorado through its constitution and many other states are required to have a balanced budget every year. We do not have the ability to have deficit spending. So the reason that these rules are being brought as emergency rules is because we have to balance our current fiscal year budget. We can't go over. I really want to emphasize the people you're hearing from at HCPF, the people that you're hearing from in the community. We are all working towards the same goals. We all want quality services available to our members. We all want access to healthcare. And unfortunately, what you're hearing is the struggle between how do we make those surgical cuts now as opposed to draconian cuts when we find that we do not have the money to fund every other part of the work that we are doing for the 1.2 million people who rely on Medicaid in Colorado. So I can't emphasize that enough. The reason we are bringing these as emergency rules is because it is an emergency now. Thank you.
Thank you, Rachel. I appreciate you. As a point of order, I do see people in the room with your hand raised. Please know that I will not be calling on people with raised hands for testimony today. We do have a way for you to sign up for public testimony. I know that Kelly, with me saying this, is going to go ahead and drop it in the link in the comments once again. If you are having technical issues, please reach out directly to the host person who will be happy to help you with any additional information you might need. I appreciate the cooperation from the community. Thank you very much. And with that, I have a list of people in the room. James, you said you were going to defer. Did you wish to speak now?
Just very briefly, Madam Chair.
Please do.
I want to thank everybody who's come to provide testimony today. This is difficult. These are always so hard. I really enjoyed coming to the meetings when we were approving new programs and new procedures and new things. It is really hard to come to the meetings now when we're saying no and we're limiting services for people. I struggle with that. I'll be very honest. And with that said, one of the things that I remember from last month and the month before, as we were talking about making sure that people are receiving the right services, that there were some folks that were, and it sounds like this is the case here as well. There's some folks that are utilizing one service, but they're actually more appropriately aligned in this other service. And so, and I don't think it's through any fault of their own. The system is complicated, very, very complicated. But what we heard over the last several months, and I don't want to put words in anyone's mouth, but what we heard over the last several months is, hey, there's probably other services that they qualify for that they're not taking advantage of, and we need to get them aligned with those services because there's pockets of money available for those services. Is it possible that the case managers, by approving this as an emergency rule now, that will give the case managers the knowledge, skills, abilities, and information that they need to help those people get aligned with the services that they would better qualify for?
Cassandra, did you want to respond to that?
Sure. Thank you, James. I appreciate your comment. I would say there's not necessarily different services that are available. There's this residential benefit, but you're right. There is a bit of a pocket of money when folks are in the appropriate billing category. There is that funding available. I want to make sure folks are aware that if you're on the developmental disabilities waiver, if you're getting residential services, you're also entitled to receive, if you have an assessed need, for day programming, behavioral services, supported community connections. There's lots of other services that are available. There's no changes happening there. So there's still that opportunity to have services and supports in other ways, just maybe not necessarily through this. But we're trying to capture those small pockets of money everywhere to try and piece them together to balance that budget.
Thank you, Cassandra. Does that answer your question, Mr. McLaughlin?
It does. Thank you, Madam Chair, and thank you, Cassandra.
Dr. Kennard, did you have a question for Cassandra?
Dr. Kennard here. Did I just have that face if I had a question? I don't think I had my hand up, but
I get messages of people who, when there's folks who are looking to speak, since I can't see you, the hosts in the room generously let me know people who are showing interest.
I'm still formulating a question. If maybe you could put me back in the line. Thank you.
Is there somebody who would like to take Dr. Kennard's place in line?
Okay, it's time to do it. Dr. Kennard here. Yeah, just coming as sort of, first of all, thank you, Adela, for saying, for framing this, I think it's just, we cannot afford the luxury of operating in a vacuum. Of course, we want to be as generous as we can in every setting. And that is not the world that we live in. And my world in the intensive care unit is a world where I came to this board because I wanted to prevent people from landing in the intensive care unit. And as a huge believer, although I'm a hospital representative, I don't care about hospitals. I care about keeping people out of the hospital. As a huge believer in that, I think it's still the emergency aspect. I think you've done the best you can in answering that. Is this an emergency, or what are the consequences? I guess I want to ask that question one more way. The consequences of not passing this as you see it. And number two, I do think going forward, we just need constant reassurance that this is part of a bigger plan. I think it's because just as it's easy to approve any increase, when you're just focused on that, it's hard to approve a decrease unless you can see it in context. And
Yeah.
and I would say that the last thing is more as a thing for us to reflect on is every service we offer, every time we establish categories, we create an industry that tries to optimize how much they can get out of it. And I don't mean the people, I don't mean the patients, I don't mean our audience, I mean agencies, right? They're in the business of optimizing that number. And so when people see these complicated systems, you have pros who figure them out. And the simpler the systems can be, at least we could understand them better as we address them. So I'm hoping that comes out of this whole challenge, is simpler systems that we can better make decisions about and are frankly less manipulable. So I guess coming around, tell us what happens if it's not passed.
If I may, this is Cassandra. I appreciate the opportunity and the reframing of what's the consequence. So the consequence would be case managers are not able to begin implementing this change and have them effective for members starting 4/1. And so they would start their service plan potentially with the incorrect rate, the wrong categorization, and we are counting on those savings, as I think Adela and Rachel said. We need to see savings in this fiscal year. So if we don't see the correct service and rate on the par beginning 4/1, we will lose that opportunity to see and realize those savings this fiscal year, and we would be not balancing the budget this fiscal year. So I think it's a huge fiscal concern that these prior authorization requests do not have the correct service reflected, and those services are not able to be reflected. I think to your other point, unfortunately, I am going to be one of many department staff that you see who are bringing forward regulations and changes that are all part of this broader picture of Medicaid sustainability. We have, areas where we are trying to make these adjustments all across the board for that bigger picture, trying to sustain the Medicaid program. So you are going to be seeing lots of these rules as part of that bigger picture of how we address this massive budget shortfall. Hopefully that gets your question. And then lastly, I think you're absolutely right. We do see provider agencies who, they are here. Some of them are here because they want to provide services, and others see that it's a great fiscal opportunity for things. They're all helping to provide services. In order to ensure members and those caregivers receive reimbursement, we have that base wage requirement. So including in this per diem service, there is a requirement that provider agency pass through a base wage. And so that's not changing either. And so, yes, the overhead of a provider agency may change, and they may see as an agency less reimbursement, but they are still required at the end of the day to pass through that base wage. And so we're very fortunate we have that in place, that Colorado is unique in that we have that. And so our hope at the end of the day is that members and their family and caregivers are not actually seeing a reduction, and the provider agency is the one that's going to take the hit.
Did that answer your question?
Dr. Kennard, yes, thank you.
You're welcome. Do I have any?
Madam President, this is Cassie Littler. I just had a quick follow-up question.
Go ahead,
Um,
Cassie.
or
Good morning.
Maybe more of a point of please reassure me. I think when we think about these cuts in a broader context or changes in classification, for instance, I think for myself, I just don't want one particular Medicaid member class to bear the brunt of all the cuts. And so I think just some reassurance that you're looking at not just people with disabilities, because it is very costly, but looking at other things, obviously, that I think may go a long way. Like you're looking at this in a broader context, right? Like all of the cuts are not just going to be in kids with disabilities and adults on the DD waiver and all of those supported services. That's just, where it worries me. That's all.
Or, if I may, this is Cassandra again. I will say the department is really focused on, a couple different areas. Long-term services and supports is a really significant cost driver in our Medicaid spending. So we're trying to make very strategic adjustments to keep those cost drivers down, because if we just continue to do things like an across-the-board rate decrease, that doesn't actually address the fact that we have continued growth and that's driving that growth. So we want to make sure that we're doing things that not only address where we're continuing to see exponential growth, but also trying to do things in an equitable way. So there are things like rate reductions across the board, but it is happening. It is spread out. We are. No one is going unscathed, is what it feels like, unfortunately, but it is not picking on any one particular type of group or disability for sure. We will see a large percentage of these initiatives impact long-term services and supports, but that's because that is where the significant cost drivers are. But everybody is feeling the pinch, unfortunately. So I don't know that that's necessarily reassuring or just really sad news to hear, but it is spread out.
Yeah. Thank you for that.
Do I have any other questions from the board? Hearing none. Well, if you can believe it, we're still on public testimony on this one, you guys. Who else has signed up for public testimony today, Mr. Sykes?
This is Chris Sykes. We have Whitney Cobb online with us.
Hi, Whitney.
I don't see Whitney online.
Oh, Whitney, this is Chris Sykes. Apparently Whitney is not online at this moment, so we will move on to Ellen Jensby.
Very good. Ellen, are you out there?
I am. Thank you. Just had to wait for to be allowed to unmute.
Sounds great, Ellen. We'll give you 2 minutes on the clock. Let us know.
Great. Thank you. Ellen Jensby. I'm with Alliance, which is a statewide nonprofit association of IDD service providers who deliver IRSS all across the state, as well as case management agencies in many of the regions of the state. So there's a lot to going into this rule. It's an incredibly difficult rule, both from just the overall policy perspective, as well as the technical perspective of what the work that went into writing this rule. And that's where I'm going to focus my comments today. So I want to thank HCPF for working with stakeholders and taking our feedback about how to very carefully structure this rule to make sure that there weren't unintended consequences on other types of IRSS settings that aren't intended to be impacted by the executive order. In particular, things like a roommate situation where someone lives with a caregiver who is one of a few staff who come in and routinely provide supports to them. That was a particularly tricky one to fit into these two categories for billing purposes. So thank you for that. And unfortunately, I think the rule is a little bit more complex than any of us would want it to be, but it needed to be that way in order to account for the variety of different settings we have. In terms of the comments that have been made around CMAs, I do want to note that our case managers and case management agencies are responsible for implementing a vast number of changes as these budget proposals unfold. And so I want to be particularly mindful that if denying this rule makes them go back and do changes to people's service plans as revisions, that will add a significant amount of additional work for case managers and potentially more confusion and delays for people who receive services. So I'll close my testimony there, and I'm happy to answer any questions that you may have. Thank you.
Thank you, Ellen. Do I have a response from the department?
Just thank you, Ellen, for your comments, and thank you for your collaboration on these rules. And I appreciate the very excellent call out that this would be a tremendous amount of work for our case management agencies to have to go back if they couldn't implement it at the beginning of their efforts. So thank you for that call out.
Do I have any questions from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on emergency rule number 12?
This is Chris Sykes. We do. We have Bryce Rafferty.
Good morning, Mr. Rafferty.
Good morning. Can you hear me?
I can, sir. Happy New Year.
Happy New Year. Wonderful. Good morning, Madam Chair and members of the board. This is Bryce Rafferty with CCDC. I'm here to support this rule, and I appreciate HCPF's goal of reducing confusion and improving billing consistency by creating two clear settings categories so rates reflect differences in service delivery. But that said, we believe the department should simplify and clarify the two settings definitions because the present wording may still be confusing in the field. Under the proposed rule, a staffed home is where services are provided by agency staff who do not serve as the primary caregiver. We encourage the department to clarify that agency caregivers and people providing support may rotate in and out and provide overnight support occasionally or regularly. This should also cover arrangements like Ellen was mentioning with 3-bed provider-controlled homes and roommate situations where a caregiver may live there but does not provide the majority of supports. Likewise, the shared living environment definition hinges on members living in the primary residence of the primary caregiver who provides the majority of total services. The core framework makes sense. The department should further clarify that other staff can still provide some care without changing the setting type, consistent with the rule's existing discussion of normal variations. We support the rule in its intent, but we amplify Ellen's suggestions to tighten the definitions with plain language and a couple of concrete examples so that providers, case managers, and families can understand and apply it consistently. Thank you. I'll yield the rest of my time.
Thank you, Mr. Rafferty. This is Laura Carroll, President of the Medical Services Board. I just wanted to clarify, Bryce, your opinion is valuable to us so much. Are you saying you would be okay with this going through as an emergency with the understanding of after that 90-day period, what's brought in as something as a final product would be clearer? Is that what you are kind of inferring, or are you saying that this rule as an emergency needs those changes?
I would say that from my standpoint, I am generally against the use of emergency rulemaking in situations that affect the areas that, Madam Chair, you were discussing in your personal comments that affect the income and have such a broad impact on a broad community of vulnerable people. That said, if this does go through, I think we need to have a general and consistent application of plain language in our rulemaking. And I think that can be provided by increased stakeholding and notice of common rulemaking. So I guess this is twofold. If this goes through, I think we need to have some clarification, whether that be through operational memoranda or otherwise, because CMAs are well overburdened and confused and applying programs and initiatives inequitably across the state on a variety of levels and with a variety of programs and initiatives. If we decide to have this go through standard rulemaking, that should be the focus. Plain language, making sure the definitions have examples, and making sure that everyone can understand this so that it gets applied evenly, equitably, and fairly.
Thank you. Cassandra, did you want to respond to either Bryce or I?
Sure. Thank you, Madam President. We would welcome the opportunity to work with Bryce and hear his feedback. We had not heard his suggestions and examples, but we would welcome those. I think first and foremost, if we can get the case managers up and running on their work, and we do have lots of additional guidance for our case managers as they begin to roll out these initiatives. But between the emergency adoption and the final version, we would welcome that opportunity to work with Bryce and get something that's more plain language. As Ellen mentioned, it is incredibly nuanced, and there are what feels like a million different ways in which someone can receive services. It is mind-boggling how many different ways it can be. So we want to make sure we account for all of those while maintaining that plain language and be as simplified as possible. So we would love to hear his suggestions and get some language from him.
Madam Chair, if I could
Yes, go
add a
ahead.
quick point. One of the issues that is pervasive as HICPUF addresses all these budget issues, and I think is just going to speak to all the rules that are here today and upcoming. The strategy of implementing all kinds of guidance and operational memoranda, I think will have a domino effect of making things much more confusing and produce more appeals and inequitable results in the long term. Because for one, operational memoranda don't have legal effect. If there's an appeal, the ALJs can't really hinge their decisions on operational memoranda. And two, as these memoranda build up, they just overwhelm the system and they overwhelm people implementing these services and administering them. So I would just urge the department that to consider their stakeholding, be very intentional about the way they word rules and conduct rulemaking generally, so that the operational memoranda don't become the primary way of clarifying and rulemaking, and that we do this right in the first place so that we don't have to come back and add guidance or conduct stakeholding once the situation gets out of control. Thank you.
Thank you, Mr. Rafferty. Do I have any other questions from the board?
Dr. Kennard with a technical question. Generally, emergency rules, as I understand it, have to come back in 90 days for final adoption.
120.
120. Is there any room to shorten that? If we approve it today, can we say we need it back in 30 days?
This is Chris Sykes. So no is the short answer to that, given the Administrative Procedures Act and how we can do public rulemaking to allow for stakeholder engagement.
Understood.
If I may, Madam President, this is Rachel Entrekin.
Please, Rachel.
Just
go ahead.
Thank you. Just adding to what Chris said, we do have constraints within the Administrative Procedure Act. So we couldn't bring it back in 30 days, but we could bring it back before 120. And I think that's what we're planning on doing in this case. So we want to make sure that, our rules are in their final form as quickly as possible without skipping stakeholder engagement.
So Rachel, hi, Laura Carroll. So that means that we could approve an emergency and they can bring the real rule, for lack of better terminology, in less than 120 days, and we can enact it in less time than that. We have that option to do so. They don't have to wait 120 days. Is that what I'm understanding?
Madam President, this is Rachel Entrekin, and the answer to that question is yes, so long as we comply with the requirements in the Administrative Procedure Act.
Excellent. I appreciate that clarification.
You bet.
Any other questions from the board? Hearing none. Thank you, Mr. Rafferty. Do we have anyone else signed up for public testimony? Mr. Sykes.
This is Chris Sykes. We do. We have Heather Wilson signed up.
Good morning, Heather.
Yes, can you hear me?
I can indeed. You will have 2 minutes on the clock. Start when you're ready.
Okay, so my name is Heather Wilson, and I have a son that is 29 years old. I have been under the IRS host home services for him since October 2015. So I honestly do not believe that I have been receiving the wrong pay rate for over 10 years now. I've had the state guidelines that the PASA owned agencies and the case management agency have used to guide me with all of these. I'm trying not to repeat what everybody else said. I also specifically requested extra help in my home for my son from January 1st to March 7th, 2025. And not once was that staffed home option ever mentioned, even though it would have been appropriate in our situation. The Resource Exchange actually had to do an emergency respite placement for my son during that time while we tried to increase his CIS level of 5 to a CIS level 6, and that did not happen. He is a CIS level 5. We have issues with the supported community connector services because we cannot find an appropriate provider since before COVID. We have never been able to do a day program because of the severity of my son's disability. He needs one-on-one. So when you're talking about extra services on top of the IRSS, my son cannot access some of those services because of how severely impacted and disabled he is. If I do fall under this 10% rate reduction with this rate alignment, it is severely going to impact my family. It's going to impact my son. I am his only care provider. I'm the only one in the home with him. The DD waiver does not have respite options on it. That is something that people like our PASA agencies try to do on a per diem basis, but yet there's no hourly respite. We have to come up with ways in order to be able to find somebody to take care of my son in order for me to go to appointments. Those things don't happen because I do not have people who can adequately provide care for my son outside of myself. And then the fact is that with the public comments were not very adequate as well.
Rachel, I'm sorry. Rachel, I'm sorry, that's time. Thank you so much for sharing your testimony today.
Thank you, honey.
Do I have a response from the department?
Sure, this is Cassandra. Thank you for your public comment and for the care that you provide for your son. And I'm really sorry to hear that services have been inadequate, that you've had challenges with your case management agency. I know that can be really difficult. I welcome you to reach out using our escalation form if you need assistance with working there. I would say that, there's absolutely some agency responsibility there. If the agency you're working with isn't able to meet the needs of your son, that's a problem, and we can certainly help with that. And then I would just point out that the provider agencies are the ones that are doing the billing. So never did I think, or do we think you've been doing billing incorrectly, but it's potentially that your provider agency. And it's not that they've been doing it incorrectly, it's that we did not define these categories well enough. But thank you for your testimony today.
Thank you, Cassandra. Do I have any questions from the board? Hearing none. Thank you for your testimony today, Heather. Mr. Sykes, do we have anyone else signed up for public testimony on this emergency rule?
This is Chris Sykes. We do. We have Corinne Jensen.
Good morning, Corinne.
Good morning.
Good morning. You have 2 minutes on the clock. Tell us all about it.
I'm not sure if I'm replying to the correct issue at hand, but
okay,
I
let's chat about it real quick, Corinne. We're talking about emergency rule number 12, which is revisions of the individual residential services and supports rules. Is that what you wanted to testify on today?
I think so. I'm a caregiver to my severely disabled husband who is likely to be affected by these quote unquote cuts or the rearranging of where the hours are put. And I just wanted to voice our disapproval of this kind of changing to what we have going on. To reduce my hours that I've had approved with the tasks approved through what I call IHSS, but I think is IRSS or something. I'm not sure why the cuts are coming down the line the way they are, I guess, is our biggest concern. To keep my husband in the home is our optimal choice, just like many other families. And to the cuts just don't seem appropriately
Excuse me,
placed.
Corinne, I'm going to jump in because I do think that you are wanting to talk to us about our rule preview that is happening a little later in the meeting. That's more where
Okay.
that whole issue is going to be discussed. I am grateful for you to be here. Hang tight. I know this meeting is taking long, but I'm going to go ahead and ask you to be patient and hang out with us so we can get through at least a couple of these rules here. I appreciate
Absolutely.
you
And
being
I
here.
apologize if I
Do
spoke
not.
out of turn.
Do not, because it took me that long to even figure it out. We're all on the same page together. Don't worry about it.
Thank you.
You're welcome. Thank you for your involvement, Corinne. Mr. Sykes, what do we think?
This is Chris Sykes. We did have an Amelia Weintraub signed up, but that individual put in, Aviana IHSS, so I'm assuming that goes towards the preview, which comments can be made at open forum.
Right.
So we will continue moving down the list. And Kelly, we have Kathleen signed up to testify.
Good morning, Kathleen.
I do not see Kathleen online.
Oh, I'm sorry, this is Chris Sykes. Kelly is telling me that he does not see Kathleen online. So let's move to Susan Root.
Good morning, Susan. Susan?
Yeah, sorry. Having a problem
Good
getting on.
morning.
Good
No
morning.
problem. You've got 2 minutes. Let us know what we need to know.
Yeah, the executive order has been on record since August 28th, 2025. There is no need to bypass full notice, comment, and review procedures. HCPF wants to avoid public scrutiny of the proposed rule. There is no administrative efficiency as cited by HCPF. HCPF is seeking to jam this rule through because they know the Joint Budget Committee is considering the budget that underlines it, and it was rejected in the last fiscal year. HCPF is attempting to shove this rule through so that even if JBC disallows it, this reduction of 10% of the daily benefits to members on DD waiver will be enacted under a cloak of a temporary emergency order, and it will be hard to unscramble the eggs administratively. They cite additional efficiencies through clarification, yet their proposed rule is even more confusing than the prior rules and policies. The rules require an analysis of who is providing how much care to understand whether a home is staffed or is not staffed. This was never been necessary in the past. HCPF states the touchstone is not the identity of the person providing the care, but the setting. But yet, they define the setting by the identity of the person providing care. This is because the real objective of the rule is not rationally tied to the cost of the setting, but to the goal of reducing the benefits of the members who reside in family caregiver homes.
Is that it, Susan?
My daughter is a 24-year-old, level 7, severely medically compromised young lady, and the 10% reduction will make a drastic impact in our lives. Thank you.
Thank you, Susan. We appreciate you. Do I have a response from the department?
Sure. This is Cassandra. There have been multiple executive orders because of this budget crisis. I want to be clear that the executive order dictating this change was October 31st. So it was not since August. So we have been working on these changes as soon as we possibly could. when learning of this mandate that the governor has given us to execute this. So we have been working diligently, as transparently as possible, holding multiple stakeholder meetings, asking for hundreds of public comments, incorporating said regulations. It has not been done under the cover of darkness and trying to hide from the JBC. In fact, if the JBC disallows this and votes no on this, and it becomes statute or some kind of change, that doesn't overrule our rules. We would defer, our rules would defer to this. So if the JBC says no, then we would be able to unwind these changes and we would do something different. It's not going to override that. So, but right now we are dictated by the governor to execute this change, and that is what we are trying to do in order to balance that budget.
Thank you, Cassandra. Do I have any questions from the board? Hearing none. Thank you for your testimony, Susan. Technical note, if we could get an IT person to check on that hand raised out in the gallery, I'd appreciate it. Thank you. And with that, do we have anyone else signed up for public testimony on this emergency rule, Mr. Sykes?
This is Chris Sykes. We do, and we actually located Kathleen.
Very good.
We're going to go back to Kathleen.
Good morning, Kathleen.
Hello there. Can you hear me?
I can indeed. You have 2 minutes, ma'am.
Okay, great. Those 2 minutes go fast, so I'm going to go fast. We are on the DD waiver. I have a 24-year-old son who is a level 5. This pay cut is going to force me to to switch to a contract position, which means that I'm no longer contributing to Social Security, which means that I no longer have employer paid health insurance. I am losing my health insurance mid-plan to switch to a contract position. And I'm going to have to switch to Medicaid under difficulty of care to provide insurance for myself. I have 2 children with disabilities, one on the DD waiver, one on the CES waiver. I personally have never been on Medicaid my entire life until I'm going to have to start now. So you're adding people to Medicaid by doing this. It's a stupid rule, and I don't understand what you guys are doing. I'm done.
Thank you, Kathleen. We appreciate you. Do I have a response from the department?
Sure, this is Cassandra Keller, and I would just want to call out that there is absolutely nothing in this new regulation or anything in our prior regulations that state how a caregiver is, how they operationalize providing services, meaning how a provider agency uses employees or contracted staff is up to that.
Can I take back my time, please? I had a minute left. Can I take back my time?
Laura, you're on mute.
I'm sorry, I'm calling for order in the space. Please do not interrupt the speaker. Kathleen, if you have other things to talk about, we don't interrupt our speakers. Please hold 1 moment till she's finished. Thank you.
Thank you, Madam President. It is up to the discretion of the provider agency whether they employ employees or have contractors. And so there's nothing in these rules precluding and dictating that she would need to change. So I'm not sure why that's occurring, but please know that that is not part of our regulations, never has or will be, whether folks contract or use employees.
Thank you, Cassandra. Kathleen, I am willing to give you 30 seconds. Please, in the future, let's be courteous to our speakers and take turns.
Okay. I understand that that's not the policy and that's not what I said. I said I'm going to have to do this to make up for the pay reduction so that I can still pay my rent and my car insurance and take care of my kids and feed them. It is not a policy. It's something I have to do so that my pay stays the same. This is what you're not understanding. Okay, I'm going to ask the board before I'm done here. How many of you could take a 10% pay cut and be totally fine with it?
Thank you for
I'm
your
done.
Thank you for your time, Kathleen. We appreciate you bringing this to our attention. Did you have anything additionally with which you would like to respond, Cassandra?
No, that's okay. Thank you, Madam President.
I appreciate you. Do I have any comments from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on emergency rule number 12?
This is Chris Sykes. We do. We have Kathy Bieber signed up.
Good morning, Kathy.
Good morning. Thank you for taking my testimony.
Happily, 2 minutes on the clock for you, ma'am.
HCPF's entire underpinning for this rule change is that a rate alignment to clear up confusion because family caregivers were supposed to be billing at the host home rate all along. This is a transparent attempt by HCPF to rewrite history that is contradicted by evidence of past practices. Until late 2024, host homes were defined in a way that excluded family caregivers. From the time that family caregivers were allowed to provide residential services in 2009 until 2024, the definition of host home specifically required that the provider be unrelated. Host home provider is an individual or individuals who provide residential supports in his or her host home to persons receiving comprehensive services who are not family members as defined by section 25.5-10-202-16 CRS. A host home provider is not a developmental disability service agency pursuant to section 8.602 of these rules. 10 CCR 2505-10.8.600. HCPF considered this definition of host home to reflect only unrelated persons and use the billing category to determine the number of host homes. This is why, when queried, HCPF can tell you that the number of host homes and the number of group homes, but not the number of family caregiver homes. Family caregiver homes were billed in the IRS category along with personal care alternatives. So it was not possible to distinguish how many of each provider there is in the higher IRS rate category. IRSS, I'm sorry. During the past 16 years, HCPF is making the incredible claim that they never noticed that the host home and group home categories only accounted for just under 50% of the people on the DD waiver. The statement of basis and purpose for the rule
Thank you,
estimates
Kathy.
that
That's
this
your
will affect.
time. I appreciate you, Kathy, so much. Thank you for taking the time to testify with us today. Do I have a response from the department?
Or I could be quick, Madam President. Thank you. This is Cassandra. I would say thank you for your testimony today. We absolutely own that there has been confusion and the regulations have changed since what you read to what they are today and are continuing to change here to try and better align these definitions with what the cost of care is. We own that we have not provided that real solid clarification and guidance, and I think it became very crucial when we're looking at the budget impact and the budget deficit, and I think that is why we are here today, is it has become under spotlight. And we are trying to, as James said, find those pockets of money, and an alignment in this way can make sure we do that and really make sure that the cost of care for these different settings and the way the care is provided are alignment and equal. So thank you.
Thank you, Cassandra. Do I have any questions from the board? Hearing none, thank you very much for your testimony. Do I have anyone else signed up for public testimony on this first rule, Mr. Sykes?
This is Chris Sykes. We do. We have Michelle Dumais.
Good morning, Michelle.
Good morning. I'd just like to jump right in. HCPF has not provided full notice and comment, nor done the required analysis. First, HCPF has not initiated this change with full notice and comment. Their stakeholder sessions only allowed comment on their definition of a staffed home and did not allow comment on the merits of this proposed reduction in member services. Second, HCPF has also circumvented CMS review of this proposed rule, stating it is not necessary, those are quotes, exact quotes, However, but CMS Regulation 441.304 requires a HCPF seek approval for changes that are, and I quote, an elimination or reduction of services or reduction in the scope, amount, and duration of any service, a change in the qualifications of service providers, changes in rate methodology, or a constriction in the eligible population. Third, HCPF has not performed the required impact analysis. They have not examined the likelihood that this reduction in funding would have on a member's likelihood of institutionalization as required by Olmstead and 25-017. We have repeatedly asked HCPF for this information, and they have steadfastly refused to provide it. Finally, HCPF recently, as early as this week, reported to the JBC that they have examined the effects of this reduction on family caregivers, which is not even the correct analysis. They did not provide any information to the public on this analysis, nor their findings. It is essential that this information be provided to understand the impact, the actual impact of this proposed change. In other words, just because you said it doesn't make it so. The nearly 200,000 family caregivers and the receivers of this care and the 6 million Coloradans deserve the correct analysis and findings. Cut costs, not care. These are cuts to care. You're using absolutely a hatchet, not a scalpel. And if what you said is true, then why are you not cutting HCPF expenditures? Stop balancing the budget on the backs of
Thank
the
you,
most
Michelle. We appreciate you very much and the time that you took today. Do we have a response from the department?
Yes, thank you, Madam President. This is Cassandra. I just want to make a couple of points. We are not decreasing services. Members will continue to have access to the same IRSS benefit tomorrow as they are today. This is not decreasing those services. It is true that a waiver amendments to our federal partners was not required, but we absolutely allowed public comment on this topic. I myself facilitated 3 meetings in which I heard the same type of testimony today. What we were clear about was that their feedback and the suggestions that they would provide, we were seeking specific feedback on the regulatory language, but we welcomed feedback across the board from all of these families and heard from them about the potential impact of this change. So we heard feedback, we received that feedback. We could only incorporate changes, though, that pertained to that regulatory language.
Thank you, Cassandra. Do I have any questions from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on emergency document 12?
This is Chris Sykes. We do. We have Jeff Dobrist.
Good morning, Jeff.
Good morning. Hi, I just wanted to clarify that I'm actually signed up for public comment on a different rule change. So I'm just going to go ahead and yield my time for right now.
Oh, Jeff, I appreciate you. Thank you so much. And if there's something in particular you need us to make sure you're signed up for, please do send it into the comments so we can make sure we get that addressed. Mr. Sykes, do we have anyone else signed up for public testimony on this rule?
This is Chris Sykes. We do. We have Tracy Anderson.
Hello, Tracy.
Madam President and members of the board, grab your pencils because I'm going to throw real life numbers at you. I'd like to show you the impact this will have on one of the highest acuity cases. For a level 6, the IRSS daily rate is currently $334.01. This proposal will reduce that to $307.64 daily. That is $26.37 a day, $9,625 a year, or $802 a month, not the $9 to $15 that Ms. Keller indicated. My son is 23 years old next week and has required 24-hour one-on-one medical care since the day he was born and will continue to do so until the day he dies. When he was 4, I went to school and earned my LPN license, and my husband earned his CNA license. We are his sole care providers and have been for the last 17 years. He has a tracheostomy for breathing, requires all feeds via G-tube. He's nonverbal and developmentally approximately 4 to 5 years of age. At a level 6, the current daily rate for IRSS at the higher billing rate level is $334.01. That is $13.92 an hour. HCPF wants to say that these cases should be able to be staffed at that rate. According to HCPF's home health reimbursement rates as of October of 2025, the rate for a CNA is $41.45, an LPN is $40.48 an hour, and an RN is currently reimbursed at $53.58 an hour. As a parent, I would not be comfortable, nor would I feel that my son was safe with any provider that would be willing to work for $14 an hour or less. The DD waiver is all inclusive, so we no longer get CNA or respite services, yet the current DD waiver daily rate is not even sufficient to cover 8 hours of a CNA, let alone an LPN or an RN. In closing, this is not an emergency. This is what it is, a rate cut to the state's most vulnerable and most needy. This is the state shifting the burden to the backs of the family members who have stepped up year after year to provide care for their loved ones, rather than putting that burden on the state to provide placement homes for these high acuity individuals at a much steeper cost to the state. Thank you for your time.
Thank you, Tracy. We appreciate you. May I have a response from the department, please?
I don't think I have a comment, Madam President, if that's okay. We can just continue with our public comments.
Sounds fine. Sounds fine. Thank you very much. Do I have any questions?
Doesn't want to argue my numbers.
Tracy, I'm sorry. I cannot have you being disruptive to our meeting.
My apologies. I thought I was muted.
Alrighty. Do you have any questions from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on this rule?
This is Chris Sykes. We do. We have Chelsea.
Good morning, Chelsea. Chelsea? Mr. Sykes, I am not hearing from Chelsea.
This is Chris Sykes. I think we're having issues with Chelsea unmuting. Kelly was just saying. Chelsea, if you can hear us, you need to accept the request to unmute. That is on the end user. We can't unmute you from our end. We can only ask. But in the interest of time, let's move on. Let's
love
move
that
on
idea.
to. I'm sorry. This is
I said,
Chris
I
Sykes.
love that idea. Carry on.
Okay, sorry. This is Chris Sykes. Let's move on to Lauren Yoakum.
Good morning, Lauren.
I don't see Lauren online, Chris.
This is Chris Sykes. Lauren Yoakum is not online. So let's move on to Martha Young.
Good morning, Martha.
Hi there. I think that when I first signed in, I wasn't sure which thing I wanted to comment on, and I signed in again on just one issue. The issue I want to comment on is the reduction in overtime hours for family caregivers. So I think I'll speak later if that works for you.
Martha, I appreciate you so much. Please make sure with admin folks that you are signed up when you should be, and we'll look forward to hearing from you then. Thank you so much.
Yeah, the first one I signed up on several because I was unclear, and then I signed in again with just one.
Wonderful. Very good. I will ask our administrators to check on that and make sure we call on you at the right time. Thank you for your time today, Martha.
Thank
Mr.
you.
Sykes, do we have anyone else signed up for public testimony today?
This is Chris Sykes. The only individual that I would say we are looking to hear from is Chelsea. If Chelsea has unmuted her mic.
I am not seeing Chelsea.
And then I'm going to defer to, this is Chris Sykes. I'm going to defer to Kelly. He is paying much more attention.
Our IT guru. Thank you, Kelly.
I'm sorry, Kelly.
Neil?
We have a Neil McDowell. Is that correct? Or,
Sure.
Neil Shermer. Sorry, they're right next to each other. Neil Shermer.
Good morning, Neil S.
Hello. Yes, thanks.
Good morning. 2 minutes on the clock for you, Neil.
Thank you.
Thank you.
So the notion that 6,000 people were billing to an incorrect rate for more than 16 years and that HICPUF didn't know about it is simply unbelievable. In its initial communication with the public regarding the cut, it stated that agencies often bill at the higher rate. Another early memorandum stated, today, some family member homes have been billing at the higher rate. To be clear, providers, family homes, and otherwise do not bill. They are not authorized to bill. Only provider agencies, in this case PASAs, bill Medicaid for services, including residential services. Importantly, however, PASAs do not decide what to bill. That decision is made by HICPUF. During initial intake or continued stay review of a member on the DD waiver, the case manager of the case management agency, or in the past CCB, develops a service plan. That service plan contains the billing codes that will be utilized by the PASA for billing services. That service plan is submitted to HICPUF as a prior authorization request. HICPUF then approves or denies the PAR. It's clear that HICPUF, not the CMA, not the PASA, and certainly not the provider, decides the billing rate for a member in service. HICPUF also has an opportunity to verify that the member's billing codes are supported by the setting in which the member lives. HICPUF, through its designated agent, CDPHE, conducts periodic audits of all PASAs and inspects the setting of member clients as part of that audit process. HICPUF's position that this is some mistake that continued for over a decade strains credulity. HICPUF's position is exposed as an outright falsehood when one considers Informational Memorandum 25-015. The memorandum is part of a series issued by HICPUF providing guidance to provider agencies. That memorandum is just
Thank you so much for your testimony, Neil. Do I have a response from the department?
For this is Cassandra. I think there has just been confusion and rules have changed. The policies have changed over the past 10 or so years since the developmental disabilities and others have moved over from the Department of Human Services. We are trying to move in the direction to where we are today. It's not that providers have been billing wrong. You're absolutely right. The case manager is the one that develops that prior authorization. It's based on feedback and information from the member and the type of setting they are. So we're not saying that it's all been done wrong for the past 10 years and now we're trying to course correct. It's that our policy was never clear. Case managers didn't have the appropriate information to be able to classify these settings into the appropriate way. Our intention to pay the higher rate for the staffed setting has our intention has not been come to fruition because our lack of clear guidance, our lack of clear information here. So the goal is to provide clarity now so that the appropriate billing can take place and that the cost of services are aligned, that we have the host home and the family settings billed at the same rate, that staff setting at that higher rate. So thank you.
Thank you, Cassandra. Do I have any questions from the board? Hearing none. Thank you very much for your testimony, Neil. Making sure that admin sees the hand up in the gallery and then checking in with Mr. Sykes to see if we have anyone else signed up for public testimony today.
This is Chris Sykes. We have Tamika Braun.
Good morning, Tamika.
Good morning. I'm wondering if my testimony may be better served at a different time.
Splendid. I will let you yield your time and I will make sure somebody from admin, please reach out to Tamika to make sure she is in the right place. Thank you, team. Do I have anyone else signed up for public testimony today?
This is Chris Sykes. We have Cindy Caldwell.
Very good. Cindy, good morning.
Hi. I didn't prepare anything, but after listening, I felt the need to jump on. I did want to clarify the woman that clearly gave the good numbers, and that's what I think we're missing is sharing the numbers. And in that, we do have to keep in mind that that our agencies, our PASAs, take a percentage of that. They can take 20 to 40%, as far as I know. And if we push more of this onto our agencies, that is also going to come back on the family caregivers because they're going to up their percentages, which they have every right to do. I had somebody from Cross Disability Coalition tell me that our agency should be providing respite. My son's a level 7. I said, what, with their $80 a day? Like, where is the money? This doesn't add up as to who's supposed to providing us with extra help. I'm a single parent of a child that doesn't need 24/7 oversight. He needs 24-hour care. And I'm just going to keep talking until my time runs out. But the distorted picture is so distorted. And yes, they listened to our listening sessions, which came back as FAQs that were very insulting and were not true. And I think people are making rules based on a not clear picture and not a true understanding of how this is affecting our community. There is a strong chance these people will end up in institutions that don't exist. You'll have to build them. My son also just got a full PD in denial based on them bringing vocabulary to this board and passing it and using it in another way. So please be careful what you pass through. Thank you.
Thank you, Cindy. I appreciate you. Do I have a response from the department?
No, that's okay, Madam President. I think I've said what I needed to say today. Thank you.
Sounds great. Do I have any comments from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony today?
This is Chris Sykes. I do not have anybody else signed up for public testimony on this rule.
Very good. I do still see a hand up in the gallery if somebody from admin could reach out to them. But seeing no one else signed up for public testimony, I would accept a motion on emergency rule number 12. Hearing none, I will allow another 5 seconds for someone to bring a motion on this rule. Hearing none, I'm sorry. I think that means this rule fails. Is that correct, Mr. Sykes?
This is Chris Sykes. I believe Dr. Littler, were you going?
I don't know. Yeah, I.
Sorry, we were jumping.
Sure.
Not putting in others.
I guess people could hold against.
I think that Cassandra, are you looking to redeem this?
I think hearing the testimony today from all of these families is incredibly impactful, and it's really, really hard. I have children, but I don't have a child with a disability. I can't imagine being in the shoes of those individuals. I understand that there is a absolutely significant chance that folks will see a reduction in their pay from this. And this is absolutely not a change anyone wants to bring forward. Unfortunately, there are going to be a lot of different changes that we are asking for that are going to impact individuals. Our real fear at HCPF is that if we don't make these smaller adjustments, that there are going to be really significant changes that come down the line. And perhaps it's not to individuals on the developmental disabilities waiver, but perhaps dental care for seniors is completely no longer covered, for an example. So I think there's a real fear that we're going to have to make harder and more significant changes if we don't do this now. It's a real risk. So if we can't make these changes, then bigger changes might have to come in the future. And while this feels really, really hard for these families, and some of these support levels may see a bigger reduction in terms of $20. Other of these service and support levels are only $1 or $1.50 a day. So Not every single person is going to see that same level of cut, but it is possible. And I don't want to minimize that at all, but the risk for future changes is real.
Cassandra, I appreciate that. I was kind of trying to give you an opportunity to pull it before we kill it. But
you,
I'm going to
Madam
try
President.
again if I can get a motion for this rule. Okay, we have no motion for this rule, so it dies, Cassandra. I'm sorry. All righty, with that, we are taking a 5-minute recess, team. Thank you.
Thank you.
Hello, hello, everybody. Welcome back, everyone.
I can hear you. I don't know about anyone else.
Can
Yep.
anybody?
We're all back
Excellent.
now.
Thank you, thank you, thank you. All righty, community, we're on to final adoption by consent. Document 1 has now got, do I count 5 people signed up for testimony on that rule, Mr. Sykes?
This is Chris Sykes. I would be very interested. The immediate answer to your question is yes. I would be very interested in those individuals wishing to testify on a rule that is just taking out long-term care out of the title of a rule section, right? That's what Nicolette's rule is. It's not, I mean, there is no rule language in the rule, it's the title. So
right, as I recall, this rule last month was a boom, boom, boom. Right, it was just a verbiage change and nothing else. Is that how you recall it, team?
This is Chris. Yeah, if you open up document 1, you will see 3 lines of text, and it's all in the title.
Okay.
There's no rule. Oh, I'm sorry,
right.
Adela.
Well, Madam Chair, I think this is Adela Flores Brennan. I think that there's a lot of confusion. People signed up to testify on something that isn't even being considered today. So there's a lot of testimony sign up for a rule preview, which, as you know, is an informative presentation about something that is to come. No decisions are being made. So I think as people have signed up for that testimony, they maybe designated the wrong rule because the rule is not actually on the agenda.
I would concur with that. Has been going on with a lot of the things that we've been looking at today. I still have to present to the board whether they wish to take this item off consent or not, because that's part of my unfortunate job.
Madam President.
Yes.
This is Chris Sykes. If I may suggest to the board and yourself,
please,
maybe with the help of Kelly, we get a couple of the individuals or all of the individuals that have signed up to testify on Rule 1. Maybe we could just informally ask them, do they actually have a comment about the rule before jumping to taking it off consent? If that
I love that idea. I wasn't sure how we felt about doing it with that quantity of people, but I'm always for polling the crowd. So Kelly's going to help me do this, and I'm going to let you help me with who we are calling up. And let's just kind of get a quick feel of what's going on here and make sure folks know what they're signing up for.
Yes, sir, Mr. Kennard.
So could we simply move the consent adoption down in the agenda? And that way, if we go through the other things, people will realize, oh,
this is
not a possibility.
I apologize. This is Chris Sykes. Board members, this is your meeting. You guys get to discuss how you would like to proceed. I was simply throwing out a possibility, but yeah, if you see something that works better for you as the board, we can facilitate it, I imagine.
I just feel like a lot of these folks are signed up for that rule. I feel like most folks are signed up for this rule preview and don't really appreciate that that's what they're signed up for. If you'll recall, that rule preview originally kind of sat in a rule situation, and it was the first one in the line. So I'm really just more concerned that folks are wanting to talk about what we're going to be talking about later. And if we take it off consent, then we have to do the whole process over again. And I'm not sure, but if Dr. Kennard is asking for that, we can do that. I'm also perfectly happy to move consent agenda to the end if that's what everybody wants to do. You guys are kind of going to have to tell me what you want. I am here to serve you. But if you guys want to move consent.
Can we move consent agenda down?
Yeah. Yeah, let's take consent agenda down and we will just move ahead to final adoption. Does that work for everybody?
It does.
Madam President, this is Chris Sykes. Absolutely, as long as the board is in agreement. I would just like to point out, when you're reading your motion for document 1 and document 2, under the consent agenda, right, they're smushed together.
Right.
If we take them off consent, you're gonna have to read it with the, incorporating the statement of basis for each document 1, and then read it again for document 2.
We're not talking
Well,
about taking it off.
that's when I count on you to
Oh,
hand it to someone in the room to sound like
Okay.
they knew what they were talking about all along, my friend.
Under final.
All
Sorry.
right, well,
Right, following. Sorry, this is Chris Sykes. I misheard that. Trying to
wonderful.
keep you all on the straight and narrow.
Yes, thank you.
Let's move on along to final adoption, shall we? And we'll come back to consent later on in the meeting. So, on final adoption, we're going to start with rules, documents, both 3 and 4. Those were going to be presented to us today, both by Erica. Are you on, Erica?
I am. Thank you,
Hi,
Madam
good
President.
morning.
Hi, good morning.
And I'm just to refresh for the board real quick. This is a rule that is both going to affect health, HFC and CHIP. And so we are reading them together because they are essentially the same bill. And then we will do a separate motion for each. Erica, when you're ready, the floor is yours.
Thank you. Good morning, Madam President and board members. My name is Erica Shaler, and I am a compliance and policy advisor for the department. I'm here to present 2 rules today, MSB 25-11-23-A, a revision to the medical assistance rule concerning coverage for abortion services, and CHIP 25-11-23B, revision to the Children's Health Plan rule concerning coverage for abortion services. Since you have already heard a detailed presentation on these rules at the emergency adoption of these rules back in November, I will keep this as just a summary of both rules. As an overview, these rule proposals implement Amendment 79 to the Colorado Constitution and Senate Bill 25-183, making abortions a constitutional right. Colorado voters approved Amendment 79 during the 2024 general election. Amendment 79 repealed the state constitutional amendment prohibiting the use of public funds to cover abortions. The amendment also added a state constitutional amendment for the right to an abortion and prohibited Colorado from denying that right in any way. Senate Bill 25-183 changes state law in accordance with Amendment 79. Senate Bill 25-183 includes abortion care and family planning related services and requires that abortions be paid with state funds only. Senate Bill 25-183 also requires the Medical Services Board to include abortion care in the schedule of healthcare services available for pregnant persons enrolled in the Children's Basic Health Plan, Rule 10, CCR 2505-3. These rule proposals seek to implement these legislative mandates with an effective date of January 1st, 2026 for both rule proposals. There are a few changes to Section 8.770, the Medicaid rule regarding abortion services. You will see some technical changes such as renumbering, changing client to member, and Colorado Medicaid to Health First Colorado. In covered services, there is a removal of definitions as well as a removal of the life endangerment and rape or incest language. Additionally, there is more expansive language in alignment with the legislative mandate. There are also some clarification on reimbursement now in the rule. Finally, the rule proposal removes certain documentation that is no longer required. The effective date of these changes added as January 1st, 2026. Regarding the CHIP rule related to abortion, Section 2505-3, there are similar but slightly different changes. First, there are technical changes such as renumbering. Next, we have the addition of abortion under preventative, routine, and family planning services. And then finally, there is a removal of the elective termination of pregnancy and life endangerment language. We have also added an effective date of January 1st, 2026. As noted previously, the department conducted a stakeholder engagement process regarding the proposed policy changes through a stakeholder meeting for the public, presentations to existing advisory groups, and held an ongoing opportunity to to submit feedback electronically. Stakeholder questions were responded to live during the meeting and through publishing a question and answer document. Stakeholder questions were technical in nature and no adjustments to the proposed policy were identified after reviewing stakeholder feedback. All feedback and the department responses are documented in the stakeholder logs for reference. Board members can access the stakeholder logs and summaries on the member website under the rules. Thank you for your time this morning. That's all I have.
Thank you, Erica. Do I have any questions from the board? Hearing none. Mr. Sykes, do we have public testimony for either of those documents?
This is Chris Sykes. I have one individual signed up for Rule 4.
Okay, and who do we have?
Andrea Fernandez. Kelly, do we have Andrea Fernandez in the meeting space?
We have an Andrea.
Let's try it.
Good morning, Andrea. Can you hear me?
Andrea does not appear to be unmuting, unprompting.
This is Chris Sykes. Kelly is asking Andrea to unmute, but Andrea is not responding. This could simply be that somebody is away from their computer at this time. But that doesn't change the fact that Andrea is not responding.
Do we have anyone else signed up on these documents, Mr. Sykes?
This is Chris Sykes. We do not.
Hi, this is Andrea. Oh, there you are. Good morning, Andrea.
If I'm still able to talk.
You are absolutely. The floor is yours for 2 minutes. Go, go, go.
Awesome. I don't know if I'm in the right spot, but I'm here just as a parent CNA. My kiddo is 14 and we receive CNA services, help with homemaker.
Okay, ma'am, I'm sorry, and Andrea, I'm sorry. We're talking about rules. Let's see here. We're talking about rules numbers 3 and 4, which are about abortion services. Do you have something to discuss with that?
No, I do not. I was in the wrong
Okay,
spot.
ma'am, then we're gonna go ahead and put you back on mute. If you would like to talk about issues during open forum, please sign up for those. If you have any other questions, please reach out to admin who will be happy to help you.
Thank you.
Mr. Sykes, do we have anyone else signed up for documents 3 and 4?
This is Chris Sykes. I believe Kelly has found Andrea with an O as opposed to Andrea with an A. Sorry,
Okay.
Kelly.
That's okay. Can you hear me?
I can hear you, ma'am. You have 2 minutes. The floor is
Hi.
yours.
You know what? I also signed up for the wrong rule. I apologize. I should be speaking at the end of the meeting, so I won't take up any more time.
Thank you, Andrea. We appreciate you.
Thank you.
Do we have anyone else signed up for documents 3 or 4 for public testimony, Mr. Sykes?
This is Chris Sykes. We do not have anybody signed up for documents 3 or 4.
Splendid. Then I will accept a motion on document 3.
Madam President, this is Cassie Littler. I move the final adoption of document 03 MSB 25-11-23-A, revision to the medical assistance rule concerning coverage for abortion services, section 8.770, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, ma'am. May I have a second?
Barry Martin, I'll second.
Thank you very much. All in favor, please say aye. Aye.
Aye.
All opposed? Abstentions?
Tina Mulkey abstain.
Wonderful.
You're abstaining, sir?
All right, so we had two. All right, so I heard Dr. Mulkey and Mr. McLaughlin abstaining. Is that correct?
That's correct.
All right, Mr. Sykes, do we still pass with that?
This is Chris Sykes. By my count, we have 6 aye, 0 nay, and 2 abstain.
All right,
If
motion
that is the
passes.
correct reflection of the board, it passes.
Blended. With that, I will accept a motion for document 5.
Madam President, this is
I'm
Cassie
sorry,
Littler.
document 4. Document 4. The first one was 3. The second one is 4. My apologies.
I move the final adoption of document 4, CHP 25-11-23-B, revision to the Children's Health Plan rule concerning coverage of abortion services, incorporating statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
Barry Martin, I'll second.
Thank you, Dr. Martin. All in favor, please say aye. Aye.
Aye.
All opposed? Abstentions?
Christina Mulkey, abstain.
Very good.
James McLaughlin, abstain.
All righty, and with that, document 4 passes. And now we move on to document 5. Danielle, are you in the house?
Morning, yes, I am.
Good morning.
All righty. Are you ready for me?
Oh, I'm so ready for you.
Wonderful, thank you. Before I do get started, I do want to just make sure to clarify, it does sound like there has been some confusion, which we've discussed at length, but the rule I'm presenting on today is not about the 56-hour caregiver cap. That item will be covered during the preview, and comment on that change can be done during open forum. So without further ado, I'll get started on my presentation for my rule. Good morning, Madam President and members of the board. My name is Danielle Kraus, and I'm the Participant-Directed Programs Team Lead within the Office of Community Living at the Department of Healthcare Policy and Financing. I'm here today to present MSB 25-11-23-C, which proposes to make permanent the revisions to the definition of the Direct Care Services Calculator and protective oversight in sections 8.7502.K and 8.7538.C.1 of the Home and Community-Based Services rules. This emergency rule is necessary to promote consistent and fiscally responsible use of Medicaid resources in alignment with current budget constraints and Governor Polis's Executive Order D 2520. We brought these rules to you initially in November as an emergency rule. We received your support and approval for this change and are proposing to make these revisions permanent today. The purpose of this rule is to establish clear, enforceable standards for authorizing personal care, homemaker, and protective oversight services, particularly for children receiving services through Community First Choice. These revisions formalize long-standing authorization practices that previously existed only in guidance and operational tools. By placing these standards in rule, the department strengthens consistency, compliance, and fiscal accountability while ensuring services are authorized only when they are clinically justified and exceed typical parental responsibilities. For many years, HCBS authorizations have relied on task-based guidance, historically referred to as norms, to determine time and frequency associated with personal care and homemaker tasks. This guidance has evolved into what is now known as task standards, which are now included in the Direct Care Services Calculator, or DCSC, which case managers use statewide to authorize services. In preparation for the July 2025 launch of Community First Choice, the department worked with stakeholders in 2024 to develop age-appropriate task standards for children, informed by nationally recognized developmental milestone resources. Operational guidance and training were issued to support implementation. However, following the launch of CFC, analysis of authorization data shows that guidance alone was insufficient to ensure consistent, age-appropriate authorizations, particularly for the children that were newly eligible for these services. With CFC, children gain broader access to personal care and homemaker services, including protective oversight, and parents or legally responsible persons may serve as the paid caregiver. While this expansion increased access, it also highlighted a long-standing Medicaid principle. Some supports are expected parental responsibilities and are not covered benefits unless a child's needs substantially exceed what is typical for a child of their age. Despite existing guidance, the department observed widespread over-authorization. We shared these examples during the emergency rule hearing, but I think it is helpful to reiterate so I can demonstrate the necessity of adopting this rule permanently. One example that I would like to share is a 5-year-old who attends school 4 days a week was approved for 135 hours of services a week. 112 of those hours are for protective oversight. The other hours that were authorized was a combination of personal care and homemaker services. The member did not have any skilled care needs, and they had a diagnosis of a developmental delay in asthma. Another example that I would like to share with you is a 2-year-old was approved for 24 hours a day of homemaker and personal care services. The majority of time was associated with household chores like dusting, laundry, and meal preparation. Children are still dependent on parents and family to manage activities of daily living like bathing, dressing, etc. at these ages. According to the current operational guidance, most of this care should not be authorized due to age appropriateness. These examples reflect systemic issues, not failures of families or case managers. Without enforceable regulatory standards, the department lacked the authority to correct these patterns consistently. This rule places clear definitions and requirements directly into regulation. First, it revises the direct care services calculator definition to require the authorizations follow task standards, including age-appropriate task standards for children. These standards reflect both the typical time required for tasks and the level of parental support expected at different developmental stages. Second, it revises the protective oversight definition to clarify that for children, the service must involve supervision or intervention that is substantially greater than what is typical for a child of the same age without disabilities. This rule also enforces that protective oversight may not unnecessarily restrict a person's movement without appropriate documentation, including rights modifications where they're required. Importantly, this rule is intended to improve enforceability on already existing expectations. I want to be very clear that this rule is not a part of the LTSS Medicaid sustainability initiatives. It is not a soft cap on services, nor does it address or change who provides the care. This rule applies specifically to case management authorization standards and practices. Making this rule permanent is critical for program sustainability. As my colleagues and our Medicaid director shared earlier today, there is an immediate need to address cost drivers given the current budget crisis. Preliminary data indicate that approximately 44% of homemaker authorizations and 58% of protective oversight authorizations for children exceed age-appropriate standards prior to the emergency rule. Permanently adopting this rule is projected to save the department approximately $8.8 million annually, which with additional long-term savings as CFC enrollment continues to grow. There are no anticipated implementation costs to the department, case management agencies, or providers. The rule clarifies existing expectations and improves enforceability rather than creating new administrative requirements. The department engaged stakeholders during the development of age-appropriate task standards and has continued to receive feedback throughout the emergency rule period. We appreciate the input from advocacy organizations, providers, members, and case management agencies, and we remain committed to ongoing training and technical assistance to support successful implementation. Since adoption of the emergency rule, we have developed resources for stakeholders and communicated changes in an operational memo. We held listening sessions with stakeholders and office hours with case management. The department has developed extensive training for case management to better support service authorization, and these sessions begin next week and are mandatory. As a result of the stakeholder feedback we received following the adoption of the emergency rule, we have made adjustments to formatting and added clarifying language to improve readability, strengthen clarity, and ensure consistent interpretation and implementation of the rule. In closing, this rule ensures that Medicaid services are authorized fairly, consistently, and responsibly while preserving access for members whose needs genuinely exceed typical expectations. Adopting this rule as permanent strengthens oversight, protects program integrity, and supports the long-term sustainability of community first choice and home and community-based services for Colorado families. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you for your testimony. Do I have any questions from the board? Hearing none, Mr. Sykes, do we have anyone signed up for public testimony on this rule?
This is Chris Sykes. We do. Currently, we have 20 individuals signed up for this rule.
Oh my
Many have
gosh.
signed up for public testimony also, so I don't know if, again, it's a mislabeling. But we're gonna go through really quickly and we will ask each individual. First up is Ronnie Broyles.
Good morning, Ronnie.
Good morning. So I would like to clarify before I begin, if I speak now on Rule 5, can I speak in the open forum as well?
This is Chris
I will,
Sykes. Absolutely.
yeah, as
Okay.
long as you are actually testifying on this rule, considering we are at 15 minutes before when we are supposed to adjourn and where we're at. If
Right.
we stray even slightly from this rule, I'm going to cut you off.
We won't. So my concern with Rule 5 is that you need case management agencies that actually follow the rules, because I'm in El Paso County and the resource exchange here is abysmal. They can't even, they openly lie to parents. They've lied to me. They have sat on my par. They have stonewalled. I've had to contact the state numerous times to get them to get the resource exchange to do their job. So my concern is, for this rule to work, the case management agencies need oversight by the state. So what are we going to do to make sure they actually follow these rules? And that's my comment.
Thank you, Ronnie. We appreciate you. Do I have a response from the department?
Yes, Madam President, thank you. This is Danielle with the department. Ronnie, thank you very much for your testimony. We very much appreciate this feedback. I will look to see if I can find the link to provide. The information that you're sharing is very helpful, and we do encourage individuals to submit grievances through our grievances form so that we can look into specific issues. But on a widespread response to you, we are doing extensive training for all case management agencies to make sure that they understand how to apply the age-appropriate task standards and the task standards for adults. And this training is mandatory for every single case manager in Colorado to attend. And we have been and will continue to provide ongoing technical assistance for these agencies. But thank you very much for your testimony.
Thank you, Danielle. Do we have any questions from the board? Hearing none. Thank you for your testimony. Do we have anyone else signed up for public testimony on document number 5, Mr. Sykes?
This is Chris Sykes. We have Andrea Grimaldo.
Andrea, are you out there? Last call for Andrea. All righty, let's move on to, so if anyone else signed up for public testimony, Mr. Sykes.
This is Chris Sykes. We have Sarah.
Good morning, Sarah.
I want to warn you, there are 2 Sarahs.
I see a Sarah Morgan with her hand raised. Can somebody check in with her, please?
With a telephone number of 919 area code. That is I'm sorry, Kelly.
I just opened her mic.
Yep.
Thank you. Sorry, I could not figure it out.
Hi, Sarah. You have 2 minutes. Go ahead.
Hi, good morning or good afternoon. I'm really just want to be clear with these rules. I think if permanent language like this is going to exist in our laws, in our bylaws, whatever they're called for this process, there needs to be clear language, because right now there is clear language, and even with that, there is still substantial room for interpretation. And in any practice, many case management agencies routinely state that they have final say on service determinations. And that leaves people very vulnerable. It also causes denials, it causes confusion, it causes delays for families to access these services, myself included. And I know you said that there is training available, but again, being told by case managers like throughout the last couple years that well, we're trained, we have these trainings with the state. It still does seem like multiple people across the state have different opinions about how to interpret these rules. So what do you guys plan to do to combat that? And I know there's the grievance process, but let's be real, that's probably an overrun system where it doesn't seem very actionable.
Sarah, excuse me. Hi, this is Laura Carroll. I was wondering if you had anything to comment on this particular rule.
Yes, with the changes to like protective oversight and launching this DCSD, there needs, how does the state plan to make sure that it's used correctly across the state and doesn't allow that open to interpretation?
Very good. Very good. I appreciate you taking the time to clarify that. May I have a response from the department, please?
Absolutely. And Sarah, thank you for your feedback and your testimony. This is Danielle Kraus with the department. To respond to your question, this rule is the first step in correcting that issue. We hear that there have been longstanding issues with confusion about how to authorize services or what's appropriate and what's not appropriate. And by implementing these rules, it is the first step for us to be able to start enforcing appropriate authorization management. In addition to that, we have developed a plethora of training materials, which many of that is going to be shared in the coming weeks with case management agencies. We've also outlined a lot of this information in detail in our operational memos for the Direct Care Services Calculator. And again, you referenced this as well, but I would reiterate, when there are specific issues going on with a case management agency, we always encourage individuals, members, whomever, to submit a grievance to our grievance form so we can look into that on an individualized basis.
Thank you very much. Do I have any questions from the department? Or I'm sorry, from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on document 5?
This is Chris Sykes. Sorry, Kelly and I are perfecting our hand signals. I apologize. Can you
I want to
speak
see more of this.
Sorry, Steel third. Oh, we have Jamie.
I'm sorry?
Jamie.
Hi, Jamie. Are you out there? Last call for Jamie. Okay, Mr. Sykes, who do we have signed up next?
This is Chris Sykes. Martha.
There is a Martha online.
I see a Martha. Hello, Martha.
Hello, I'm the one that I changed my comment section, and I don't believe I'm commenting on this. I'm commenting on the 56-hour limit.
Sure.
So you're
Thank
for
you.
the
We'll
for the
you.
preview.
Yeah.
Very
Public
good.
testimony. Yes.
Thank you.
Would you make that magic happen, Mr. Sykes?
This is Chris Sykes, absolutely.
Thank you, sir. Do we have anybody else signed up for document number 5?
We have Shannon Warner.
Hello, Shannon.
Hello, can you hear me?
I can. You have 2 minutes.
Okay, I am also commenting on the 56-hour cap.
Fantastic. We'll talk to you at public record. Thank you very much. Is there anyone else signed up for document number 5 today, Mr. Sykes?
This is Chris Sykes. We have Megan Bowser.
Good morning, Megan.
Good morning. Thank you, Madam President. I would like to comment on this particular rule.
First, I want to appreciate the department's work to clarify the language in this rule. We've gone back and forth several times trying to make sure it is clear as possible so that it is enforced consistently throughout the state. I understand the need to make clearer boundaries, both on protective oversight and on the services outlined in the direct care services calculator as a whole. My concern with this is that we are moving away from more person-centered planning, and we will more consistently see case managers approving the maximum number of hours for every member that they evaluate. We would love to see the department bring more ideas on how to make planning more person-centered, more individualized, rather than us seeing case managers consistently approve the maximums and the savings being established just by moving the bar of where those maximums exist. Protective oversight in this new rule is focused very heavily on interventions and doesn't necessarily acknowledge the 24/7 on-call line of sight that is needed to be ready to intervene when these come up. While I acknowledge that the state cannot pay for 24/7 supervision for every member that needs it, we would ask the board to request that HCPF revisit the ways to make the service more reflective of the differences in the intensity of supervision for children and the idea that someone is on call, unpaid, ready to intervene as the rule sits today. While I understand the board will likely approve this rule as it is today, and I don't necessarily disagree with that, I would very much encourage HCPF to come back with a more robust way to provide this protective oversight service in a way that acknowledges the supervision needed, not just the interventions needed as well. Thank you.
Thank you, Megan. Do I have a response from the department?
Yes, this is Danielle from HCPF. Thank you, Megan, for your testimony. I really appreciate your feedback and the insight that you're always willing to share with us. I want to just respond and say, I hear you. It sounds like there's still some work that we need to be doing to ensure that our training is comprehensive. We definitely don't want to stray away from person-centered support planning. And so we do take this information and your feedback and your testimony, and we will continue exploring ways to ensure that all of our services are person-centered and comprehensive in how they are provided. So thank you.
Thank you. Do we have any questions from the board?
Madam Chair, James McLaughlin, just a very
Go
quick
ahead.
comment. Just a thank you to Megan. I really always appreciate her insight and her opinion. It is very, very valuable. So thank you for that.
Heard and +1, Mr. McLaughlin. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony?
This is Chris Sykes. We do. We have Chloe Weber.
Hi, Chloe. Good morning.
Hi, I was hoping to speak on the 56-hour cap as well, so I must have clicked on the wrong button. So I'll wait and talk later.
Very good, Mr. Sykes. I'll add you to the list for that public comment. Mr. Sykes, do we have anyone else signed up for public testimony on document 5?
This is Chris Sykes. We have Jessica Hopkins.
Good morning, Jessica. Did you wish to comment on document 5? Last call. All righty, hearing none. Do we have anyone else signed up for public testimony on document 5, Mr. Sykes?
This is Chris Sykes. We have Summer Zero.
Good morning, Summer.
Hi, can you hear me?
I can, Summer. You have 2 minutes.
Hi, great. Thanks for letting me talk. I also would like to speak at the public commenting if possible, but I would like to just start. So I actually have 4 disabled children with very high extensive needs who just recently were enrolled in the CFC services. And I do just want to make you guys aware that the rules that you are putting into place, I know that originally when explaining this change, saying that there's not going to be caps, according to the case managers training, what they are getting and what they are telling families like myself is that there are going to be caps on those services based on age appropriateness. So, for example, I'd like you to just kind of put yourself in my shoes for a minute. I have a 13-year-old who is developmentally delayed. He has seizures, he has autism, he has a traumatic brain injury, and he elopes constantly to the point where he is deemed to need 24-hour eyes on him. In the past, before these services were rendered to families and there was not protective oversight available, there were moments where I would use the bathroom and come back and he would have escaped in the matter of minutes. He has broken windows with his face. He has broken glass doors with his body. And just like another commenter had mentioned, I think that when there are these stipulations put on families that really fall on families to get documentation showing, oh, this kid is worthy of, this much protective oversight or not. And also, like another commenter had mentioned, that there are, families who are on 24/7, basically, standby. We don't get to choose when our child tries to elope or tries to break things with their bodies or self-harms or all of those things. And so I think there needs to be maybe an adjustment to how those hours are allotted, and not just, oh, this child is this age, therefore they should only get this amount of protective oversight, or, oh, because this child is, smaller, they don't need that.
Thank you, Summer. We appreciate you. Do I have a response from the department?
Yes, this is Danielle from the department. Thank you, Madam President. Summer, thank you for your feedback. Very enlightening and helpful to hear. I do think that some of that will be good feedback to provide for the rule preview that's being presented later today, as it sounds like a lot of that's related to the soft caps. However, I hear what you're saying about protective oversight, and thank you very much for the feedback.
Do I have any comments from the board? Hearing none. Mr. Sykes, do we have anyone else signed up for public testimony on rule number 5?
This is Chris Sykes. We do not have anybody else signed up to testify.
Splendid. I would take a motion on document 5.
This is JP Costello, Madam Chairperson, so moved.
Okay, I need you to read the motion, please. Thank you, sir.
Yes. Move the final adoption of document 5 MSB 25-11-23-C, revisions to the direct care services calculator and protective oversight definitions, sections 8.7502.K and 8.7538.C.1, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Costello. May I have a second, please?
Madam Chair, this is James McLaughlin. I'll second that.
Thank you, Mr. McLaughlin. All in favor, please say aye.
Aye.
All opposed? Abstentions? Very good. Document 5 passes. On to document 6. David Smith, are you in the house? Mr. Sykes?
I am, Madam.
Oh, there you are.
I am, Madam President.
All right, well,
Madam
the floor is yours.
Thank you so much. Madam President, members of the board, my name is David Smith. I'm from the Medicaid Operations Office, and I'm here to speak to you on behalf of the Fraud, Waste, and Abuse Division. On document 6, the rule regarding the technical changes to the RAC program, by way of recap from the emergency rule adoption back in November. The recovery audit contractor is a federally mandated program. It was first passed in the Affordable Care Act, and the obligation on the department pursuant to this program is to recover overpayments from providers as well as identify underpayments. The intent of requesting adoption of these changes is to clarify that the program integrity rules in existing regulation do not apply to the RAC program. And the rationale for this request is that the General Assembly adopted back in this last legislative session, comprehensive rules governing the RAC program. So to have both provisions in Senate Bill 314, as well as provisions in the program integrity rules in our regulations would cause confusion in amongst our stakeholders. There are three simple changes that we're requesting final adoption on. I'll try to run through these in quick workmanlike fashion, as well as highlight in Senate Bill 314 where we have more prescriptive provisions regarding the conduct of these audits. So the first provision in subparagraph G, documentation not received by a provider pursuant to a RAC audit would automatically be deemed an overpayment. So that's existing rule. However, in Senate Bill 314 in subsection E3, providers are responsible for making relevant records available. Pursuant to subsection L, Roman numeral 5, there are a series of levels of review prior to deeming overpayment, and in absence of going through those procedural steps, we don't have authority to deem findings and overpayments. So this is an important clarification. The second provision under subsection H in our existing regulations, it describes an interview process with providers. I don't want this board to be under the misunderstanding that we're cutting out interview processes and the ability for providers to interface with the department. In that regard, subsection C, Roman numeral 3, capital C in Senate Bill 314 provides an absolute duty upon the RAC contractor to respond to inquiries within 2 business days. But vis-a-vis audit findings, preliminary findings under Senate Bill 314 go through an exit conference step, and as well as an informal reconsideration step prior to, at which time providers can bring any evidence, records, testimony, as well as meeting with the department prior to deeming these findings an overpayment. So again, Senate Bill 314 is more prescriptive and differs substantially and significantly from the existing program integrity rule. The third change deals with notices of overpayments in our existing rule. Well, again, Senate Bill 314 does not deem audit findings automatically an overpayment until the due process steps have occurred. The exit conference for complex audits, as well as the informal reconsiderations step. Since the adoption of this rule as an emergency rule in November, the department has released several audits, and I thought I'd just describe those briefly as I can, just to give you a little context as to what this looks like. There are 2 pilot audits, one dealing with emergency medical transportation, as well as duplicate professional claims. Pilot audit means that we've released them to a small number of providers and are testing the audit scenario to ensure that it's viable prior to releasing to a greater population. We do also have some full audits in play. Preliminary findings on those audits were mailed out to providers on December 29th. 3 of those audits deal with pediatric behavioral therapy providers, and there's a additional full audit that deals with non-emergency medical transportation. And again, preliminary findings on those audits were mailed out on 12/29. Since our discussion back in November, I've had the opportunity to describe these changes to the Provider Advisory Board. Under House Bill 23-1295, there's a separate board that the RAC team interfaces with to help advise it on developing these audits. Back in December, I talked to them about these rule changes, and we've also notified stakeholders regarding these changes as well. So with that, I will conclude my testimony, and I'm more than happy to answer any questions. But in summary, I encourage you to support the final adoption of these changes.
Thank you, David. Do I have any questions from the department?
Department or board?
I'm sorry, from the board. Thank you.
Just again, trying to keep everything in context here, because I have two questions. Number one is, it seems like these rule changes are largely in order to fall into compliance with the new laws. Is that true? Just you mentioned the Senate law, Senate bill, and House bill that have changed your procedure. So is that, am I understanding that right?
Dr. Kennard, David Smith, you are spot on.
Okay.
As well as reduce confusion amongst our stakeholders.
See, so that said, if I'm understanding, correct me if I'm wrong, it seemed like 3 procedural changes, all of which making it more difficult for the department to declare an overpayment, meaning they have to go through over more hurdles, spend more person hours, and time, and so person hour dollars going into declaring and thus and presumably recovering an overpayment. I guess I'm confused about why in this environment that we have just heard so heartbreakingly from, that there's this emphasis on, oh, gee, we don't want to be busting people for overpayment so easily. So I'm not sure why, but that said, if it's the law, it's the law, and I will vote to approve it. If it's not the law, I will not vote to approve it, because it strikes me as I have no, frankly, sorry for being overly no sympathy for case management and provider agencies. I have sympathy for patients, and this seems to be making it easier, not on patients and clients and members, but on providers. So I think we should be holding to higher standards, not lower.
I appreciate those comments, Dr. Kennard, David Smith for the department.
Do we have any other questions from the board?
Well,
this is Chris Sykes. I don't think David had the opportunity to respond to Dr. Kennard.
I apologize. From here, it sounded like he thanked him, and then there was a pretty long silence. Please continue.
No, my apologies, Madam President. I was cogitating. So the RAC program has had 3 bills in the course of, I think, 4 years, or 2 bills in the course of 3 years. I'm a little dyslexic, which in my experience in the government relations realm is a highly overused word in this day and age, but unprecedented. So it's a very politically sensitive program. And I think that stems from the RAC contractor that we had in place and providers not feeling like the process was very fair. I think with my characterization vis-a-vis Senate Bill 314, the final bill relating to the RAC program, is that the program will be much more fair for the providers, but will also reduce the friction on the department, which has prevented it from properly carrying out this federally mandated program. So, you know, my personal feeling on this is that I'm cautiously optimistic in a more fair program and a more orderly process so that we can get to the business of identifying overpayments and as well as educating the provider community on how to submit a clean claim, as well as being good stewards of the public fisc on behalf of Colorado, so that we can recover some monies through the RAC program.
Thank you.
Do I have any other questions from the board?
Laura, if you're talking, we couldn't hear you.
Can you hear me now?
I believe that's my fault because my.
Hello?
There you are. I'm sorry. My system decided to mute itself.
Oh, I thought it was tired of my voice. Do we have anyone else signed up? Anyone else from the board with questions? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 6?
We do. We have Britta in the room. Britta, would you like to talk about the RAC rule?
Is this about the hourly cap?
No, that will be an open forum. This is about the recovery audit contract.
No, I will be open.
Okay, just wanted to make sure. Thank you.
Thank you for checking.
Yes, since I already messed up once. Kelly, do we have Belle Hayes with us?
I can see.
Hello, I was hoping to testify about the 56-hour cap. There's been some confusion around that, so I apologize.
Thank you. Alrighty, Mr. Sykes, anyone else signed up for this rule?
This is Chris Sykes. We do have Jeff Dobrist again, but Jeff, do you want to talk about the recovery audit contract rule? Or do you want to talk about the 56-hour rule at open forum?
Yeah, my apologies. It's going to be the 56-hour rule at the end.
Perfect. Just want to make sure. Madam President, there is nobody signed up for testimony on this rule.
Wonderful. Then I will accept a motion on document 6. Last call.
Are you gonna do it?
Yeah, Madam Chairperson, this is J.K. Costello.
Thank you, JK. Go ahead.
Move the final adoption of document 6, MSB 25-11-23-D, revision to the Medical Assistance Act rule concerning RAC program technical changes, sections 8.076.2.G, 8.076.2.H, and 8.076.2.I, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second, please?
Madam Chair, this is James McLaughlin. I'll second that one.
Thank you, sir. All in favor, please say aye.
Aye.
All opposed? Abstentions?
Dr. Kennard abstaining.
Thank you, Dr. Kennard. I show that as document 6 passing. Do you concur, Mr. Sykes?
This is Chris Sykes. Yes, we have 7 ayes, 0 nays, and 1 abstention.
Fantastic. How are we feeling about final adoption by consent? Team, do we want to try and open that door again?
Madam Chairperson, it seems like there are a lot of people that want to testify on one thing, and we're spending a lot of time running through people who don't want to talk about these. Could we message people who are signed up for final adoption by consent and initial approval comment and clarify what they want to comment on and maybe avoid?
Dr. Costello, that has already happened. We are so on top of it, JK, you don't even know. So
I
that
don't.
question's probably more directed towards Mr. Sykes. Have we heard back from any of those consent agenda people?
This is Chris Sykes. Kelly O'Brien is shaking his head no.
Very good. Then I'm sorry?
That we have not heard back.
Fantastic. In the interest of time and agenda, can I please have a motion for final adoption by consent for documents 1 and 2?
Dr. Kennard here. I move the final adoption of document 1, MSP 25-7-2-A, revision to the Medical Assistance Act rule concerning removal of long-term care single entry point from section 8.300, and document 2, MSP 25-8-12-B, revision to the medical assistance rule concerning vision services update, section 8.203, incorporating the statement of basis and purpose, specific statutory authority contained in the records.
Thank you, sir. May I have a second?
This is James McLaughlin. I can second that.
Thank you, Mr. McLaughlin. All in favor, please say aye.
Aye.
All opposed? Abstentions? Fantastic. Adoption by consent is finished. Onward we go to initial approval. We are starting with document 7, and it looks like Greta Moser and Erica Shaler are going to be taking this one. Are one of the two of you with us?
Yes, we are both, and I'm going to pass it over to Greta for presentation.
Hi.
Very good. Yes. Good afternoon, Madam President and board members. My name is Greta Moser, and I'm the Benefit Manager for Federally Qualified Health Centers. I'm here to present the revision to the Medical Assistance Rule concerning Federally Qualified Health Centers, Section 8.700.6.B, which is Document 7, MSB 25-07-01-F. House Bill 25-1288 was signed into law on May 27th, 2025, and authorizes federally qualified health centers to establish separate subsidiary companies for the purpose of providing fee-for-service services. This proposed rule revision adds subsidiaries for specific services to the list of circumstances for which federally qualified health centers may receive fee-for-service reimbursement, aligning the rule with House Bill 25-1288, which directs the department to pass rules for implementation. The services included in the proposed rule, if provided at a federally qualified health center, are captured in the cost report and then paid indirectly through the per visit encounter rate. The process of cost reporting and updating the federally qualified health center encounter rate takes time, which means the costs related to providing services like the ones included in the proposed rule are not fully accounted for in the per visit encounter rate right away. A fee-for-service subsidiary lessens that delay in payment for these services and provides financial sustainability for federally qualified health centers, which ensures vital access to health care for Medicaid members. The fee-for-service reimbursement for subsidiary services may be passed through the subsidiary to the federally qualified health center and must be kept separate from the federally qualified health center's cost-based reimbursement rate. Fiscal note analysis indicates subsidiaries will not have a budget impact as payments for services subsidiaries will be providing are just being shifted from the federally qualified health center's per visit encounter payment to fee-for-service reimbursement. The department consulted Colorado Community Health Network, the state's membership organization for federally qualified health centers, and Salud Family Health Centers when drafting the proposed rule language. Thank you. Please let me know if you have any questions.
Thank you, Greta. Do I have any questions from the board?
Madam Chair, this is Cassie Littler. I have a couple questions. Just in the rule on 8.700.6A, the last sentence refers to the short-term behavioral health services and primary care setting policy. And I just wanted to know if that is that really what the policy still is, or should it be updated to the integrated care benefit in primary care? Since the short-term behavioral health services has been shifted to the capitated behavioral health benefit.
Yes, that's correct. We might need to make updates there. That is not what this rule revision is focused on. I don't know if that matters.
I was reading the whole rule.
Yeah, this rule revision is for 8.700.6.b.
Okay, sounds good. Then in that case, my question is for patients who have Medicaid based on Cover All Coloradans, and those patients being removed from the ACC and no longer in MCOs. Just wondering about if they would need to be considered under an FQHC subsidiary for fee-for-service for primary care services outside of the ones that are listed in the 6.B section. I don't know.
Sorry.
Yes. Thank you for the question. That might be something I have to take back to the department and follow up on. I am not sure what that means for Cover All Coloradans. If that's okay.
Yeah, no, I appreciate it. Just want to get clarification. So I appreciate you taking that back.
Sure.
That was Greta Moser responding.
Yes. Sorry.
Dr. Martin, that's okay. Dr. Martin, I see your hand.
Yes, thanks, Barry Martin. I'm certainly in favor of this, but I'm curious about in the analysis, it says that there'll be no cost to HCPF. It seems to me like if it's going to increase revenues to the FQHC, that money has to come from somewhere, and I'm wondering how it is that there'll be no additional cost.
Thank you for the question. This is Greta. So we don't really see this as an increase in cost. It's really the timing of payments rather than the federally qualified health center providing one of these services at the federally qualified health center, which would mean the department would increase the encounter rate for the federally qualified health center for providing those services. We'll be paying a subsidiary company to provide those services fee for service. So it really is a shift, and the difference between the cost-based reimbursement and the fee for service is really timing of those payments. Does that help?
It does, but it, for a large community health center that has a very large budget, I'm wondering if this expense would have changed their budget enough to cause a significantly increased rate in their FQHC rate, as opposed to getting the money right up front. So I'm all in favor of it. It's just curious accounting, I guess, to me.
Thank you. This is Greta. This might not be what you're speaking to, but if a federally qualified health center chooses to form a subsidiary to provide certain services, they cannot also provide them at the federally qualified health center. So we wouldn't expect them to be receiving fee-for-service payment and then also have an increased encounter rate.
Does that answer your
Thanks.
question, Dr. Martin? Excellent. Do I have any other questions from the board?
Yeah, Madam Chairperson, a couple questions, and Greta. So my understanding,
That's Dr. Costello speaking. Go ahead.
yeah, it is. Two questions. One, my understanding the encounter rate is that it's meant to compensate them for all these things they do, some of which are more profitable, some of which are less profitable. This is happening in behavioral health too. It seems like an enterprising provider would take more profitable services and run them under a subsidiary for fee for service and not put them in the encounter rate. No?
Encounter rates are higher.
Yeah, no encounter rates are good, but I guess like what services would happen this way? Like what do you first see happening? Because it just strikes me as kind of vague that they can just set up subsidiaries. I get that it's faster, but what additional services do you see happening that wouldn't happen under the current system from these subsidiaries?
Thank you for the question. We know that one federally qualified health center plans to open a subsidiary for lab services. And the other services include, and that's the only federally qualified health center that we know with plans to open a subsidiary. These other services that are included in the proposed rule, we worked with Colorado Community Health Network and also recognize that these are services that get paid indirectly at the federally qualified health center encounter rate. So I don't know that that fully answers your question, but you can restate it.
Kind of, I mean, it's good to have the example. That's helpful. So I mean, it seems like we're making a rule for one FQ to add some services. Would the subsidiaries also, my maybe poor understanding of FQs is they have certain enabling services that they have to provide. Would these subsidiaries, translation, things like that, are these subsidiaries governed by the same rules or are they exempt from them?
For the question, that's a good question. My initial reaction is no, they are, since they are considered a completely, yes, Erica, go ahead.
Nope, I'll go after you. I just wanted to remind the board too that we are doing this rule in response to legislation that was already passed. Yeah, go ahead, Greta.
Yep. My initial reaction is no, they would not be required to provide those same services. They are a completely separate entity from the federally qualified health center, but I can take that back and confirm.
Okay. I mean, they're less than arm's length, right? They're passing through all the profits to the FQ, so they're not a unrelated entity.
That was Dr. Costello speaking.
That was Dr. Costello.
That's correct.
One more question, Madam Chair.
Please go ahead.
Do we know if this happened in other states, or is this are we pioneering this? Are we the canaries in the coal mine, the guinea pigs?
We are not aware of other states doing this. It could be happening in other states, though.
Does that do you, Dr. Costello?
Good, thank you.
You betcha. Any other questions from the board?
Dr. Kennard, very quickly. So I understand that the benefit of this is faster payment to the federally qualified health centers. And that's, so number one, just that's kind of a yes or no question. And my comment is fee for service makes me nervous. I think maybe that underlies JK's comments. Like somebody's going to figure out how to make money off that. And I hope there will be follow-up, as I always ask. See what happened. Oh, suddenly there's a booming derm clinic going on. So just as long as we follow up.
Yeah.
Thank you, Greta from the department. Federally qualified health centers that choose to operate a subsidiary, they will have to run a subsidiary that meets the requirements in the proposed rule language, so they can't just open up a subsidiary for any service. Additionally, federally qualified health centers with subsidiaries will have to report on their subsidiaries, the costs, and provide adequate documentation to the department with their federally qualified health center cost report to illustrate that the subsidiary is completely separate and that there's no overlap in services or costs. There's no duplicate payments that are happening, if that eases your concerns at all.
Dr. Kennard, thank you.
Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on this rule?
This is Chris Sykes. We do not have anybody signed up to testify on this rule.
Very good. Then I will accept a motion on document 7, please.
Madam Chair, this is James McLaughlin. I can take that one.
Please do, sir.
I move the initial approval of document 07 MSB 250701-F, revision to the Medical Assistance Act rule concerning federal qualified health centers, section 8.700.6.b, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I have a second?
Madam Chair, this is Cassie Littler. I second.
Thank you, Cassie. All in favor, please say aye.
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 All opposed? Abstention? I'm sorry?
Nay.
Thank you, Dr. Costello. Any abstentions? I heard one nay, no abstentions. Is that correct, Mr. Sykes?
This is Chris Sykes. That is what I heard.
Very good. Then document 7 passes initial approval. All right, team. So here's where we're at here. We are well overdue for a recess. I'm going to put us into recess for 5 minutes. When I come back, you're going to have a new chairperson for this meeting. I am handing the realms over to my dear colleague, Dr. Martin, because the HCCUF chose to give us such a very thick and impossible agenda to fill in the time that we are expected to be here these days. I am going to have to drop off at 1 o'clock to continue with the rest of my life. I will be back to listen in for those last 15 minutes, and then at 1 o'clock, I'm dropping off. All right, we are in recess for 5 minutes.
I have a hard stop at 3 as well. Just
If we're still here at 3, something's gone terribly.
If they keep y'all here till 3 and you don't quit, I will be very disappointed.
Also thinking. Long band. Either band. That's a full cover. Let's get folks out of jail.
So we're gonna say.
Yeah, as long as you don't have a.
I don't
show good thing they're paying, so they'll do this, huh?
now.
They're behind on their payment.
Sorry.
The folks from,
I asked you just as you put.
I'll never come back to you for overpayment, that's for sure.
I mean, there was a big overpayment to go from the rates. And it's like, we're gonna be paid, but you know what I realized was that, you know, you very think about right now, providers don't.
So, no,
free cash, waiting for you to pay it, right? And you know, so they get overpaid and I mean,
Damage was the prime.
script, right? Which is tax, we get to letters. And then, you know, it's like if you had a big apparent change in a year. You Yeah, and so it's, you know, I get like, obviously, you try to be perfect about everything. But also like, wasn't expect to go to some nice.
Yeah.
Just comes back to us and expect them.
Or that healthcare.
So,
The rural.
you know, I can see the professional. I see that all the time,
Talk about
rack
what that
and
role.
really
I mean, they're gonna have all the.
sometimes
They're gonna have all the EMF leaders across the state.
Right, that's like.
Yeah.
Speaking out,
Because for every
general
year,
non-meeting term, I
There's
mean,
another story.
it's a.
Hello, everyone. I didn't set a timer, but I think we're about time to
Right.
get going again to.
Sign for.
And it's.
Hey, Barry.
In behavioral health.
Is the.
Can you all hear me?
Yeah.
Turn them up.
That's as loud as it goes. Barry, can you use your outside voice? Cause our speakers are maxed.
Is this any better?
Yes.
There you go.
Sorry, all right, I'm on a headset, so I think we're moving on to document 8. And let's see, I'll have to pull up who's presenting.
That would be Nancy Brennis.
And do we have Nancy with us?
Yes, hello. It would actually be document 8 and 9 are both mine.
Oh, great. Let's do them both together.
Alrighty then. So I will proceed. Good morning, board members. Thank you for your time today. My name is Nancy Brennis, and I'm the Adult Medical Policy Specialist for the department. I'm here to present the rule change for re-entry services for incarcerated individuals. Currently, 8.100.3.G.B.II states that incarcerated individuals have Medicaid coverage limited to an inpatient stay of 24 hours or longer in a medical institution. The proposed rule change will add a re-entry services authorized through the 1115 demonstration waiver as a Medicaid covered service to incarcerated individuals that are 90 days before their release. These changes are being implemented to clarify an exception to the current language and in accordance with Section 5121 of the Federal Consolidation Appropriations Act of 2023. Section 120.1.c is also amended in accordance with the Consolidation Appropriations Act, which includes a provision that modifies CHIP eligibility requirements for children and youth who become incarcerated. This rule change also seeks to modify Section 210.u to add that case management services are a covered service for incarcerated individuals that are 90 days from their release, as authorized through the 1115 demonstration waiver. As to who this would cover, to qualify for services covered under the Colorado's 1115 waiver amendment approval, individuals residing in a correctional facility must have been determined eligible for Medicaid or CHIP pursuant to an application filled before or during incarceration. Individuals should also have an expected release date within 90 days. I would like to address potential questions regarding the budgetary impact of this rule change during a tough fiscal environment. Some money does need to move to implement the 1115 waiver authority. It's also true that there are new administrative resources needed to implement the 1115 reentry waiver authority. However, given the state's difficult budgetary circumstances, the money movement and new cost of the new administrative resources has been achieved in a budget neutral manner via Senate Bill 25-308. This is being done by establishing the cash funds for the SAVE general fund and paying the cost of the administrative resources out of the cash fund. This initiative is budget neutral and eventually budget positive, as increasing federal funds are drawn down to offset the cost of services which had previously been paid by the general fund only. I would also like to make it clear that the state is already providing and paying for these reentry services. They are not new services. The current payment of these services is made using general funds only, resources appropriated by the Department of Corrections. So this waiver will now allow federal match for those reentry services rendered to Medicaid eligible individuals in Department of Corrections facilities. This federal match will help offset the costs that have previously been paid only by the Department of Corrections appropriated general funds. The same Senate bill also gave us the administrative resources and the state budget authority to transfer those SAVE general fund resources into a cash fund that we're federally required to use to reinvent and expand reentry services. As mentioned earlier, the proposed change in this rule is also being made to become compliant with Section 5121 of the Consolidations Appropriation Act, which states state plan services should be provided to incarcerated youth in Medicaid and the Children's Health Insurance Program. The department has issued memo IM 24008, which provides details on the 1115 waiver demonstration and its available benefits. No updates will be needed to the Colorado Benefit Management System to reflect this change. Is there any questions that I can answer for you at this time?
Hearing none. Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We do not have anybody signed up for public testimony on document 8 or document 9.
And I assume we have to take these one at a time. We can't combine them as far as, so I would entertain a motion for document. I would entertain a motion for document 8.
Acting Chair, this is James McLaughlin. I can handle that.
Go ahead, Mr. McLaughlin.
I move the initial approval of document 08 MSB 25-11-20-A revision to the provider incarceration services section 8.00.3.G.B.II, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thanks so much. Is there a second?
Dr. Kennard, seconded.
Great. All those in favor?
Aye.
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 Opposed? Abstentions?
I abstain. This is Dr. Costello.
Okay, the document passes. Same for document 9. Can we have a motion?
Mr. Chair, Acting Chair, this is James McLaughlin. I can handle that one as well.
Thank you.
I move the initial approval of document 09 CHP 25-12-01-A revision to the provider incarceration service section 120.1.C and 210.U, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thanks so much. Is there a second?
Dr. Kennard, seconding.
All in favor?
Aye.
Aye.
All opposed? Abstentions?
This is JK. Abstain.
Document passes. So we're now moving on to document 10. And Mr. Sykes, who do we have presenting on document 10?
This is Chris Sykes. We have Corey Conelaw.
Hello, everybody. This is Corey. I'm here. All right.
Look forward to your presentation.
Wonderful. Thank you. Good afternoon, Acting Chair and members of the board. My name is Corey Conalog, and I am the Pharmacy Policy Specialist for the department. I'm presenting Document 10, MSB 25-10-7-A, revision to the Medical Assistance Act concerning pharmacy reimbursement methodology update, Section 8.800.13. As you're all well aware, Colorado is facing an acute budget crisis, and to address this, Governor issued and later extended executive orders to implement budget reductions authorized under Senate Bill 25B-001. As part of these reductions, the department is updating the pharmacy reimbursement methodology for covered outpatient drugs. There are three parts to this rule change. Currently, claims for prescription drugs are reimbursed at the lesser of average acquisition cost, AAC, National Average Drug Acquisition Cost, NADAC, or NADAC, or submitted ingredient cost. If an AAC or NADAC rate is unavailable, the claim is then reimbursed at the lesser of the maximum allowable cost, MAC, or the submitted ingredient cost. Under the revised structure, the reimbursement will now be the lesser of the AAC, NADAC, MAC, or the submitted ingredient cost. So previously, the MAC rate would only apply when AAC or NADAC rates were unavailable. The second change is that the MAC rate will also be updated to wholesale acquisition cost minus 22% for generic drugs and wholesale acquisition cost minus 4% for branded drugs. The current MAC rate is WAC minus 20% for generic drugs and WAC minus 3.5% for branded drugs. Lastly, this rule reduces the lowest two dispensing fee tiers from $10.25 to $9.93 and from $9.31 to $8.72. Dispensing fee tiers are determined by total annual prescription volume and are a fee paid on most prescriptions. This is meant to cover a pharmacy's operating costs, so pharmacies with the highest prescription volumes receive lower per prescription dispensing fees. The two dispensing fee tiers affected by the proposed change will impact the pharmacies with the highest total annual prescription volume, or pharmacies who choose not to participate in the total annual prescription volume survey. These changes implement required pharmacy program reductions under the governor's executive order and Senate Bill 25B-001, while spreading the impact broadly across enrolled pharmacies. The department is requesting these changes to be effective only for the coming fiscal year, though that's not guaranteed. The rule is projected to reduce overall pharmacy reimbursement expenditures by approximately $6.5 million in federal fiscal year 25-26, reflecting the combined impact of the revised reimbursement formula, updating MAC rates, and lowering dispensing fees. The department considered other cost-saving methods and ultimately structured these changes to spread the impact most broadly across the pharmacy network, limiting disproportionate effects on single providers or critical networks while maintaining benefits for our members. The department has received some feedback on this rule. Some stakeholders have expressed concern about the decrease in reimbursement for pharmacy providers, while others have noted their appreciation for our approach in distributing the impact more broadly. We recognize that any reduction in the reimbursement may create challenges for our providers. The department does remain committed to making thoughtful, targeted cost reductions that support the long-term fiscal sustainability of the pharmacy benefit while safeguarding the services that our members depend on. I kindly ask for a yes vote, but first I'd like to address any questions or feedback from the board and the community.
Board, any questions or comments?
This is James McLaughlin. So this is the outpatient pharmacies at the hospital, correct? When the patients are discharged, or is this for inpatients?
This is Corey Conalanga with the department. This is mainly retail pharmacies.
Retail pharmacy, okay. That was the only question I had.
Any other questions?
Mr. Chairperson, this is JK.
Yes.
And Ms. Connaught, I just wanted to commend you because this is really complex and I don't fully understand all of it, but I appreciate you emphasizing the changes are going to fall more on larger pharmacies, not government and small and rural pharmacies. And it seems like a reasonable change to save a significant amount of money. So thank you.
This is Corey from the department. Thank you. I appreciate your comments.
Any other board questions or comments? Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We do not have anybody signed up for public testimony on this rule.
In that case, I would call for a motion on document 10.
I'll move, Chairperson. This is
Go
J.K.
ahead,
Costello.
please.
Move the initial approval of document 10, MSB 25-10-07-A, revision to the Medical Assistance Act concerning pharmacy reimbursement methodology update, sections 8.800.13.b, 8.800.13.c, 8.800.13.h, 8.800.13.I, 8.800.13.j, and 8.800.13.k, incorporating the statement of basis and purpose and specific statutory authority contained in the records. Thanks.
All right, after that mouthful, is there a second?
This is Laura Carroll. I'll second.
Okay, Ms. Carroll. All those in favor, say aye.
Aye.
Any opposed? Any abstentions? Document 10 passes, so let's go on to document 11. Who do we have, Mr. Sykes?
This is Chris Sykes. We have Grant Reefer with us today.
Take it away, please.
Good afternoon, Mr. Chair, members of the board. My name is Grant Reefer, and I am the Home and Community-Based Services Benefit Specialist for Residential Services. I am here today to bring forth revisions to the Home and Community-Based Services regulations that will create efficiency in service delivery and certification processes. The changes I'll be presenting today revises 10 CCR 2505-10, section 8.753 related to mental health transitional living homes. The purpose of this rule is to transfer the oversight authority for MHTLs from the Colorado Department of Public Health and Environment to the Behavioral Health Administration, or BHA. When these rules were originally adopted, the BHA had not yet been fully established, so CDPH&E was designated as the oversight authority, and providers were required to obtain licensure as an assisted living residence. Since that time, the BHA has been formally established, has regulations and licensure structures in place, and is now prepared to assume this role on behalf of HCPF. Under the revised rule, the BHA will provide oversight, which includes licensure as a behavioral health entity and endorsement for MHTL homes, verifying that providers meet all applicable licensing and regulatory requirements. Providers will be directly affected by this change. While they will need to obtain licensure through the BHA with an MHTL endorsement, they will no longer be required to maintain assisted living residence licensure through CDPH&E. As a result, the providers may experience overall administrative and cost efficiencies. There are 5 MHTLs currently operating, and HCPF is working directly with these providers to obtain the new license and ensure a smooth transition. This change better aligns oversight of the MHTL homes with a behavioral health focused regulatory framework. These services are intended to support members with severe and persistent mental illness in the most integrated and least restrictive settings, and they require staff trained to respond to mental health needs, including crisis situations. The department respectfully requests that the board approve MSB 25-10 9-3B as presented. Thank you, and I'm happy to answer any questions you may have.
Board members, any questions or comments?
This is James McLaughlin. Just a quick comment, Mr. Chair.
Yes, sir.
Thank you. Again, James McLaughlin. I love it as an agency that's recently been licensed through the BHE or BHA as a BHE. Sorry. I will say that they have been working very hard to make that process efficient and effective. And so I think that I just want to say that I appreciate that, and I think this is a great transition. But also, I'd like to put this caveat in, and I know there's nothing we can do right now, but an entity that has to be licensed through the BHE and through CDPHE and then billed through HIGPUF has to go through three separate sets of regulation, three separate sets of getting the exact same set of fingerprints to do the work that they do. And when they renew it, they have to do that every single time. And if they ever have an issue, they have to report to three separate bodies for any sort of oversight for a complaint or something like that. And that is an incredible burden on an organization or on an entity. And it continues to be that way. I realize we can't do anything about that today, but I just want to mention that we have to find a way to streamline this process. It's not reasonable to expect organizations or entities to be licensed through three separate entities and go through all these different steps over and over and over again. There needs to be some sort of clearinghouse in the future for that process. Again, I know we can't do that today. I think this is a great step, and I just wanted to take a chance to say, I hope sanity comes to this process in the future, and we can have a unified way to make it easier for the entities that are doing the work. Thanks, guys.
Mr. Reefer, any comment?
Yes, this is Grant Reefer. This rule change will actually remove the requirement to be licensed under CDPH&E current rule. This completely removes them from the licensure requirement and moves authority to the BHA.
Yeah. And I absolutely get that, as long as they're not doing any other services that require a license under CDPHE. It's when you do anything else that requires you have to go through a lot of the same hoops and jump through a lot of the same hurdles over and over and over again, because this agency is not allowed to share fingerprinting with that agency. And so you find, especially for smaller agencies, it becomes a huge regulatory burden, and that burden becomes even greater if there's ever an incident, because you have to report that incident to each and every single agency individually while you're trying to hold your organization together and help your people heal through what is probably a tragic situation or at least a dramatic situation. So hopefully not tragic.
Anything
so
else,
I thank you for this. I agree. I think this does help.
Mr. Reefer, any other comments?
Yes, Grant Reefer. I appreciate your comments, and I'm only speaking to the rule for mental health transitional living homes. I can't speak to the other licensure requirements for those facilities that carry multiple specialties.
I totally understand, and thank you. Thanks for being here today, and I think you did a great job presenting.
Any other questions or comments from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony?
This is Chris Sykes. We do not have anybody signed up for public testimony.
In that case, I will entertain a motion on document 11.
This is James McLaughlin. I can take that.
Thank you, Mr. McLaughlin.
I move the initial approval of document 11 MSB 2509-03-B, revision to mental health transitional living homes, section 8.7532A through G, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Is there a second?
I'll second that. It's Dr. Costello.
Great, thank you, JK. All in favor, say aye.
Aye.
Opposed, nay. Any abstentions? The rule passes.
Yeah.
So that's great. Thank you all for that. Thinking about what rules could go on the consent agenda, it seems to me that all of the ones on this initial approval agenda were fairly uncontentious. I would propose putting them all on consent agenda for next time, unless anyone has any objections.
No objections.
Okay.
Great, thanks so much. So I will now read the closing motion. Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. Can someone second?
Second, Dr. Kennard.
Thanks. That concludes the meeting, and we will now move on to rule review with Ms. Portero.
Yes, thank
Hope
you.
I pronounced your name correctly.
Yes, you did. And I believe I have slides that Kelly was going to help me present on the screen. If that's still possible, I can get started. Great. So thank you all. Good afternoon, Mr. Chair and members of the board. My name is Maddie Cortaro, and I am a policy advisor in the Office of Community Living. Today, I will be presenting a preview for an emergency rule that you will be reviewing next month. While I understand that rule previews are not the standard for emergency rules, we wanted to take some time to provide context behind the changes for the medical assistance rule concerning Medicaid Sustainability Initiative changes connected to Community First Choice and Community Connector, and also discuss the time constraints that we are under. This preview will touch on points made earlier in this meeting pertaining to the governor's executive order and the state's budget crisis. And to further preview our work for the board, I do want to note that the measures slated for April 1st effective date are only the first batch of several changes. We have a lot of moving parts that we need to implement towards a sustainable long-term services and supports ecosystem. However, we have more time to implement the other measures, and we plan to pursue the ordinary non-emergency process with those rules. Finally, today's preview is informational only. We continue to encourage and invite stakeholders to provide comment through our Google form, which I believe also Kelly has a link to that he can put in the chat. And that form and our rules have been posted since mid-December. So next slide, please. So I first want to just talk about some of the context around the need for change. As many of you know, and as previously stated in this meeting, Medicaid consumes more than 1/3 of our state's budget. This year, our state has experienced limited revenue growth from Tabor and other fiscal constraints. On top of that, there have been federal policy changes like HR 1 that are increasing the state's financial obligation. With that, the state faces a structural budget deficit. Without action, Medicaid long-term services and supports, otherwise known as LTSS for an abbreviation, Medicaid LTSS costs will specifically outpace revenues, meaning that if we don't take action now, nearly every single new general fund dollar will need to be dedicated to Medicaid, which will leave no funds for other state funding obligations. So we have to take action to ensure that our program spend aligns with the funding we have available. Next slide, please. So when we look at potential changes, we needed to first analyze the drivers of trends, cost trends, to better address all controllable factors that are significantly increasing cost.
I just lost.
We
Wait.
I think we're all frozen.
Oh.
Uh-oh.
Oh, sure did. Oh, no, there it is. You're good.
Wait,
She's back.
We're back.
Should I keep going?
Madeline, I'm sorry, yeah, apparently my private Wi-Fi is unstable.
That's okay. Am I good to keep going? Or
Yes,
okay.
I think you're all set.
Perfect, thank you. So we first, we wanted to analyze the drivers of trend to address all controllable factors that are increasing costs. So we are, of course, always looking to maximize federal funding, which is why we implemented programs like Community First Choice, which receives an enhanced federal match for services. We want to make sure we're making thoughtful changes to services. So we analyzed our benefits and looked at where our reimbursement policies are not typical or out of alignment when compared to other state Medicaid programs, or are associated with the trend that we simply can't afford. Our goal, our ultimate goal, is to avoid draconian cuts, to maintain access to these critical services over the long run, which in many cases means pulling back in the near term on unsustainable trends. Next slide, please. So one statistic that you will often hear is that the LTSS population serves just 5% of the Medicaid population, but it consumes 42% of overall spending. And that's standard across the nation. Serving people with disabilities and older adults are what Medicaid programs are designed to do. And appropriately so, these services are expensive. However, this creates perhaps a disproportionate responsibility to make sure the LTSS programs fit within our funding and are available now and in the future. When we look at home and community-based services waiver programs, we can see that there's significant growth in enrollment. For example, there's a growing enrollment and increased demand among children and older adults. The state also anticipates future increased enrollment with the rapidly growing aging population in Colorado. Then, once members are enrolled in these programs, they are utilizing significantly more services than they have in the past. So what we know is that without changes, LTSS spending will exceed funding available. And the sooner we can address the unsustainable trends, the less deep reductions we need to make in the future. Next slide, please. So next, I want to dive into the specific growth for the main benefits that we are addressing through the rule set for February. We have conducted data analysis to better understand how we can maintain access, but ensure we can afford it. Community Connector is a service that we are taking multiple actions on because costs have increased by more than 600% over 5 years, making it one of the most expensive per member services in the children's waiver system. In fact, payments have increased from $5 million to $67 million, a cumulative increase of roughly 1,200%. In-home support services has experienced a 260% increase, and homemaker and personal care have experienced a 70% increase. These are just a few key trends that we are targeting with the sustainability actions that I will discuss in more details in the next few slides. Next slide, please. So this slide outlines the executive orders that we've been talking about. And that these initiatives specifically are tied to. On August 28th, 2025, the governor issued an executive order which initiated $252 million in budget reductions for fiscal year 25-26 across state agencies, including $79 million in reductions to HCPF. And 4 of those reductions were targeted at the LTSS programs. On October 31st, the governor issued another executive order, which initiated $13.5 million in additional reductions for this fiscal year. Next slide, please. The specific executive order initiatives that need a spring implementation date are outlined on this slide and are the crux of the emergency rule you will see next month. Those include age restrictions and service limits for the Community Connector service, which is available through the Children's Extensive Support Waiver and the Children's Habilitation Residential Program Waiver, unit caps for personal care, homemaker, and health maintenance activities, a limit on caregiver hours per week per member, and ensuring that the 16-hour existing daily cap for caregivers remains in place, and reducing the legally responsible person homemaker hours from the existing 10 hours per week to 5 hours per week. Next slide. I will dive into the specific rule changes now that you will see next month. So one more slide, please. There are several changes connected to the Community Connector rule. To set us on track towards making this service sustainable, updates include a new unit limit of 1,040 units per support plan year, and mandate that the service is only available to school-age children, which in Colorado, per Colorado statute, this means any child age 6 or older. Consistent with and bolstering those limits, updates have been made to the Community Connector service rule to clarify that the service is for addressing members with exceptional needs that exceed age-typical parental or legal guardian responsibilities and require ongoing support to engage with, integrate into, build skills, and utilize natural community resources. Next slide, please. There are several rule changes connected to the service unit caps, which seek to set guardrails preventing overutilization. In addition to the language setting out the caps themselves, we have created new definitions, including a definition for the age-appropriate task standards for children and the age-appropriate task standards for adults, which, as my colleague Danny mentioned in her rule presentation, are tools that case managers are currently using. Additionally, we have defined the standard responsibilities of parents and legal guardians to ensure consistency when case managers are authorizing services. We have also developed language on the exceptions process that case managers may use to request additional units above the caps where truly needed in individual cases. Next slide. For the weekly caregiving hours and the legally responsible person homemaker hour initiatives, we have clarified the existing definition for a legally responsible person. We've amended the existing 10-hour per week limit to 5 hours per week of homemaker when provided by a legally responsible person. We've also clarified that a member can have up to 2 legally responsible persons that are reimbursed for homemaker. We've clarified which services the existing 16-hour per day caregiver limit applies to. Additionally, we've created new language to establish a 56-hour per week per member caregiver limit, which includes the provider agency's responsibilities for enforcement. Our expectation is that this approach will reduce caregiver burnout, incentivize provider agencies to continue diversifying their paid caregiving staff beyond parents and families, and ultimately enhance the sustainability of this workforce. And next slide. Finally, we have cleaned up some additional sections of rule to ensure that these initiatives are implemented on a consistent basis. For example, we've removed the language around the nurse assessor and skilled care acuity assessment, as that tool is no longer in use. We've also moved the extraordinary care definition from a specific benefit section to a broad definition section to improve the overall structure of our rules. And next slide, I will explain why this rule set will come to you as an emergency. So one more slide, please. So to explain why we are running these via emergency rule, I wanted to go over the implementation roadmap and milestones. As previously mentioned, the state is experiencing severe budget constraints that require immediate action to ensure responsible administration of Medicaid-funded services. With Governor Polis's executive order issued on October 31st, 2025, HCPUF must implement budget sustainability measures in the spring of 2026 to ensure a balanced budget this fiscal year and in the future. These changes must be reflected in members' person-centered support plans starting April 1st, 2026. Members with an April 1st, 2026 certification date will begin the person-centered support planning process in February. So to support case management agencies in managing their workload, we are asking for an emergency rule to be adopted in February. And these actions must be taken again to ensure Code of Colorado regulations aligns with the governor's executive order. And then one more slide. I did want to point out that while we are running these via emergency rule, we have been conducting extensive stakeholder engagement. Dating back to November of 2025, after the executive order was issued, OCL hosted several webinars and solicited stakeholder feedback regarding the implementation of these mandated changes. In December, we posted a draft copy of the rule revisions along with a feedback form, and we have and will continue to incorporate stakeholder feedback wherever possible. So thank you all for allowing me to present this preview, and thank you for your time, and we will see you next month.
Great, thank you so much. I'm told that there are only 2 board members left in the room. I think we still have Dr. Mulkey in addition to myself on the Zoom. Any comments or questions about this from the board?
Mr. Acting Chair, this is James. Just a quick request.
Okay.
I was wondering if we could have that presentation mailed to us or emailed to us. That was it.
This is Chris Sykes. Yes, I will share this presentation with all the board members.
All right, so thank you for that. Remaining board members, I'm told that we have 25 people signed up for comment on the open forum. If everybody gets 2 minutes, that'll be another 50 minutes for all of us. Any thoughts about how to proceed? Are you all able to stay for that long?
Acting Chair, I only have about 25 more minutes. Unfortunately, I do have a 3 o'clock meeting that I have to attend.
Dr. Martin, this is Rachel Entrican. Adela and I are in the room right now. We also have folks on the phone from the Office of Community Living who, between this group, we could keep it going for public comment. I know folks have been waiting a long time to be able to give their comments, and it's important for us to hear them.
All right, so it sounds like we'll march ahead. Thanks for that clarification. Mr. Sykes, who do we have signed up for testimony?
Our first is Brita. She's in the room with us.
All right, take it away. And we can set the timer, please.
Yes, hello, good afternoon. My name is Britta. There are over 584,000 caregivers in the state of Colorado, and cutting skilled CNA hours is going to actively destabilize the most cost-effective and high-quality solution that we have. Being a parent CNA and an IHSS caregiver is unlike any job in the world. You stand by your child as they go through things that a child should never have to go through. You have the privilege of knowing that your child is receiving the best care because you are doing it. Putting a cap on your child's hours is a death sentence for some. Each child is individual, and some need more than others. My child is 24 hours a day. Having the adequate hours to pay covers all the necessities that Medicaid will not cover, like braces, support pillows, hospital beds. The list is long. Maintenance and gas for your vehicle, because breakdowns for a child with disabilities is a life and death situation. Managing an airway and secretions at 4 a.m., making sure that they have oxygen and their vent circuit is clear. Generators in case of an emergency so that your child doesn't stop breathing. Having enough hours to support your household costs, including your huge electric bill, because your child could be on multiple pieces of DME at all times. Covering your own medical insurance costs to make sure that your mind and your body are able to weather the wear and tear of caring for a child for 24 hours a day. To whom this may concern, Governor Polis, legislators, committees, whoever is making this decision that determines our fate. If you were in this situation, what would you do if it was your child or loved one? Where is your conscience, your compassion, your dignity? Staying home with your child as their full-time caregiver helps prevent the contraction and spread to your child of flu, COVID, measles, RSV, and any other contagion or unknown infectious disease that an immunocompromised child is always susceptible to. You cannot contact trace people coming through your house. When you decrease the hours of a parent and you implement other caregivers, you are putting your child at risk.
Thank you so much. Right on the dot. Mr. Sykes, who do we have next?
Thank you.
Thank you for your time.
Thank you.
Next up is Shannon Moore.
Hi, I will try to be fast. This is Shannon Moore. I'm a parent caregiver to a medically complex child. I'm here to talk about the 56-hour caregiver cap and how it affects family like mine. We're already capped on how many hours can be worked in a day, and that cap has already been difficult. Adding a hard weekly cap would not add protection for our family. It would take away stability. Care for my child does not stop at 56 hours a week. Her needs are daily, constant, and medically necessary, including nights and weekends. There's often language about building a care team or relying on a village. For many families like mine, that village does not exist. Outside caregivers are extremely hard to find. Turnover is high, and most family members already work full-time jobs. Asking families to recruit and manage multiple caregivers on top of a full-time care creates more strain, not relief. In our household, my child's father is also a listed caregiver. I'm thankfully not like a single family household. He works a full 40-hour job outside the home while also providing caregiver hours. Restricting both parents to a hard 56-hour cap would force impossible choices, either giving up stable outside employment or being required to recruit outside caregivers to cover approved hours. Let's see. Parent caregivers provide consistency and medical awareness that cannot easily be replaced. We are not choosing long hours for convenience. We are filling gaps that no one else is available to fill. I'm asking that meaningful exceptions be allowed for parent caregivers or medically complex children, not just short-term fixes, but ongoing flexibility that reflects real caregiving realities. Families like mine want to keep our children safe at home. We want stability, not disruption. Thank you for listening.
Thank you so much for the testimony, especially waiting all this time, to all of you. Mr. Sykes, who do we have next up for testimony?
We have Aaron Moore.
Sorry, there's no Aaron Moore
Oh, I apologize. Aaron Moore is no longer with us. Rosemary Harrison.
Hi, I'm here.
Go ahead, Ms. Harrison.
Hello, everyone. My name is Rosemary Harrison. I'm the single parent of a 3-year-old daughter with hypotonic cerebral palsy. She is tracheostomy and ventilator dependent, receives all nutrition through a feeding tube, and cannot take food by mouth. Although she requires total physical care, she is fully cognitively aware and understands, communicates, and engages with the world around her like any other toddler. My daughter requires 24-hour skilled caregiving to remain safe and at home. My family relocated here specifically so I could provide that care for her, as well as provide for her siblings who are also 4 and 7 years old. I am her primary caregiver and a paid caregiver, not by choice, but by necessity. Despite working extensively with local nursing agencies, we have not been able to secure safe and reliable home health nursing for my daughter's level of medical complexity. We previously had a nurse assigned, but that nurse allowed my daughter to suffer a head injury and she had to be terminated. Since then, no agency has been able to provide suitable replacement. If a 56-hour cap on caregiver hours is implemented, I will no longer be able to financially sustain my family or continue providing care for my daughter that she requires. I do not have extended family nearby who can step in, and institutional placement such as hospitalization or facility care is not appropriate for her well-being, as well as there's no facilities in the area to accommodate her. Relocating out of state is also not a viable option for my family. This proposed cap would directly and severely impact my daughter's health, safety, and quality of life. Without my ability to provide full-time care for her, she would be at risk of losing her stable, attentive, and medically knowledgeable caregiver she depends on every day. I am asking that you consider real-world consequences of this policy on children like my daughter, children with profound medical needs who cannot safely go without consistent specialized care, and on families who have no alternative options. Thank you for allowing me to share my experience.
Thank you so much, Ms. Harrison. Mr. Sykes, who do we have next?
This is Chris Sykes. Do we have Barbara Frazier with us? Barbara Frazier.
Yes, I'm here.
Go ahead, Ms. Frazier.
So I would like to start with an already existing legislation that affected our situation regarding government immunity for certain hospitals in the area. We would not be in the position or the need for these Medicaid services, which is 24/7 hour care by me for my husband, and it is just my husband and I. Our children are moved away. We don't have anybody else in our family that can take on the burden. If we had been able to get compensation for the right vertebral artery nick of a surgeon that caused 8 strokes for my husband, which left him debilitated, humiliated, and left to have his wife wipe him because he can't even do the most basic tasks. So I ask that before this be a passed rule, that we look at the different situations. While a lot of what you will hear is on the children's behalf, my husband is only 63 years old. It cost him his whole career. It cost us a whole lifetime of dreams and goals. As a result, I lost my job, and I am taking care of him. This is my only way of employment. If my hours are cut, to be able to afford to continue care, I'm also going to have to get another part-time job. It puts mental exhaustion, it puts poor quality of care for my husband, and it puts our family in a very poor situation. So I hope before you pass this that you will give careful consideration to what you're looking at. I have no choice. There is no way possible for me to reduce my hours. There are not just me in this situation, there are many others, and I hope you will consider my words today.
Thank you, Ms. Frazier. Mr. Sykes, do we have more people signed up for public testimony?
This is Chris Sykes. We have Tony Shackleton.
There we go. Okay, can you guys hear me now?
Yes, we can. Thanks. 2 minutes.
All right. Well, thank you for taking the time to talk with us. I understand that this is kind of a governor-driven rule, so maybe it would be useful if somebody could. What actually do we have control over? Because it's interesting. We just found out about this at 9 o'clock last night here. But I guess the overview is there's a lot of talk about avoiding draconian cuts by implementing this. In our situation, I'd be looking at about a 50% pay cut. So that qualifies as non-draconian, but that's pretty severe. And it also says that it's supposed to help us prevent burnout caretakers by having us take a second job on top of the 56-hour job we already got. So that's kind of a crazy thing too. And then also I would like to know how we can justify all of these extra steps for approval. Like, for example, we went through this whole process with Telegen to get all these hours approved, and I guess they're just thrown in the shredder and we're getting 56. So I would like to speak how that's money worth spending. That's it.
Thank you so much, Mr. Shackleton. Chris Sykes, who do we have next?
We have Summer Zera.
Hi, can you hear me?
We can. Go ahead. 2 minutes, please.
Hi, yeah, just like I spoke on earlier, cutting services to 56 hours is not a budget adjustment. It's a death sentence for thousands of families like mine. Right now, there's a huge, severe shortage of providers, yet the department claims that this cap is protecting caregivers from burnout. That is simply not true. Caregivers will still be working the same hours, will just be paid less or not at all for these hours. There are not providers lining up to work at 3 a.m. on holidays or on weekends. Provider turnover in this field is exponentially higher than in any other profession in this country. The pay is so low that you can earn more working at McDonald's than you can caring for medically fragile disabled children or adults. This policy targets the most vulnerable population while imposing some of the steepest cuts I have reviewed across the medical services. I have 4 disabled children with extraordinary medical and developmental needs. For 9 years, we have seen our case managers send out provider profiles, which is how you find caregivers, every single month. 9 years, we have not had one response, not one, because you do not pay enough. It is not sustainable for any person to provide those hours except for parents. Not one person in the system seems to understand that except for the people who are living it every day. The proposal is insulting to families who already do so much with such little rest and such little compensation. This is built on this false reality that there is this huge flux of providers that there isn't. As I stated earlier, without 24/7 protective oversight, nursing care, and many other services for families like mine, children would die, and it would increase the budget that we are spending because of the amount of influx of hospitalizations, institutional need, and injuries to children because they are not, and adults who are not getting these care services. So I really hope that you think about and put yourself in the shoes of families like mine and see how this is not going to help. It's going to hurt everybody involved. Thank you.
Thanks so much for your testimony. Mr. Sykes, who do we have signed up next?
Mr. Martin, could I just make a really quick response to that one? I don't intend to make a response to all of them. I know we're trying to get through, but would that be okay?
Go ahead.
Awesome,
Yeah.
Thank you. Summer, I want you to hear me. While I don't know exactly what your circumstances are, because I don't have your lived experiences, I want you to know your words are heard and you're heard. As a paramedic, I've spent the last 25 years responding to calls in communities and seeing folks with developmental disabilities, and complicated healthcare challenges. And I know, some of what you're saying, and I just want you to know that we are not taking this lightly. This is a pretty significant thing for us as well. And when we make that decision, when it's brought to us for a decision, I want you to know that your words do matter, and you won't be forgotten. We hear you and we see you.
Thanks so much, James. I think that captures how we're all trying to deal with this. As, just to use this forum to say, for me, it's difficult when we know we need to make cuts, but it's difficult to know how you cut one place and not another. And, how much cut does any one thing have in, how big a difference will it make to the budget compared to other things that could be cut? So this is a very difficult situation. Mr. Sykes, do we have anyone signed up for more testimony?
This is Chris Sykes. We have Rachel Meza.
Are you with us, Rachel?
I am. Hi.
Hi, go ahead. You have 2 minutes, please.
Hi, I am also a live-in caregiver of a disabled medically complex child. She relies on a G-tube for all of her nutrition. She is physically disabled, and without the use of her braces and her walker, she really cannot move around independently. She needs assistance with all activities of daily living. To reduce our hours to 56 hours a week doesn't mean that I work less. It doesn't mean that I get a break. We have looked for nursing care in the past as well and have not had any success. We were able to get a nurse one time during COVID, and she refused to wear her mask around my medically complex child who is at risk of contagion. So I don't have other options. I don't have family in state who is able to help me take over. Many of us are in the same boat, and I just want to stress how difficult this situation will be for all of us. I will have to pick up another job to work another job on top of the 56 hours is almost impossible because no job is going to be as flexible as we need to accommodate for all of the different things that come up with being a parent of a medically complex child. And furthermore, if I require her to be watched by someone, some kind of childcare during that time, she really doesn't qualify for the majority of programs. She can't get after school care. She can't be watched by a regular babysitter. It's expensive and very difficult to find. So I just want to stress how reducing our hours will only make it more difficult to provide for our children for the things that Medicaid does not cover.
Thanks so much. Mr. Sykes, do we have anyone else signed up for a testimony?
This is Chris Sykes. We do. We have Anna Davidson.
Anna, are you with us? Mr. Sykes, should we wait or move on?
This is Chris Sykes. Kelly is saying that he cannot find Anna on the webinar right now. So we're going to move on to Shannon Moore.
Shannon Moore, are you with us?
Hi, I actually did already speak with you guys.
Great, thanks so much.
Thank you.
Anyone else, Mr. Sykes?
We have Pam Rogers.
Hello? Hello? Can you hear me?
Hello. Hello,
Hey.
Pam. We can hear you. Yes, go ahead.
Sorry.
2 minutes, please.
I have no voice, so I'm going to do my best here. My name is Pam. I provide 56 hours of direct care to my medically complex children each week based on their safety and needs. This does not include the additional hours I spend documenting care, ordering supplies, coordinating appointments, supervising and training caregivers, and ensuring all services are in place. I rely on approved skilled and unskilled home health services to cover the remainder of their care. Cuts, limits, or reductions to caregiver hours and rates put family at extreme financial risk and place medically complex children at high risk of not receiving essential care. Colorado has no pediatric nursing homes. Home-based services are literally the only option. Without these supports, children face unnecessary out-of-state institutionalization, which is not only traumatic for the child and family, but also significantly more costly for the state. I understand that budget cuts are necessary, but why was a wait list or waiting period never considered to manage growth before the state reached crisis? Has the state considered the potential costs of out-of-state placements? Does the state have any plan to build pediatric nursing homes? HCPF, what is the plan if these cuts, limits, or changes go into effect and families cannot safely provide care at home? How will children and adults receive skilled and unskilled care 7 days a week indefinitely if services are reduced? At my home, we take it one day at a time, praying my children can remain safe with the care model we've built over the past 7 years. If the system is disrupted, several of my children will require hospitalization and/or institutional care, creating unnecessary trauma and costs for the state. Please consider the real consequences for families like mine.
Thank you, Pam. Mr. Sykes, who is next?
We have Victoria Moore.
Victoria, are you with us?
Yes, can you hear me?
We can. Thank you. Go ahead. Give your testimony.
Thank you,
You've got
Chris.
2 minutes.
I think, and I need to bring this up, I think that we're missing a key component here. And I find it hard to believe that there's a lot of educated and well-educated people in the room that aren't thinking about this. I don't know. When I went to college, they taught me about wraparound theory for my social work degree. Wraparound theory is a very important and integral piece of taking care of the disability community. In that theory, it is that all services, all care are individually based. The community itself is gathered around that individual or that family to provide support. And I had to do a whole semester on wraparound theory and its impact on the community. And it seems like everybody's forgetting that component because I have yet to hear HCPF in their big words of save, save, save all the time, what they're going to do about the money that they're going to need extra in buckets like food stamps, TANF, housing services, childcare subsidy, and possibly even shelters. Because the one thing that nobody talks about is when you take away the income level from the services from these families, they're going to go without housing, they're going to go without food, they're going to go without, well, they're going to have the ability to put their children in childcare if they can even do it. So we're saving money on this side, quote unquote, but we're not putting money or coming up with an idea where to put money in these other buckets to continue the wraparound theory that these families are going to desperately depend on. So we're talking about a whole lot of saving, but in reality, once these cuts are made, you guys are going to have to come up with an even worse budget to fill these other gaps because those families are going to depend on those other services. If you haven't worked around wraparound theory, I don't know, maybe take some time and research it. Thank you.
Thanks so much, Victoria. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Belle Hayes.
Hi, I'm here.
Hi, we can hear you clearly, so go ahead with your 2-minute testimony.
Okay, thank you. The proposed 56-hour caregiver limit will affect many across Colorado, including our family. I take care of my mom. She's authorized for about 75 hours. My mom has a mental impairment and can be very aggressive and combative with people. My mom needs 24/7 supervision due to safety concerns. This new rule is proposed to alleviate pressure to single caregivers, but ironically, it will do the opposite. This is already a very low paying job. I made much more money when I was not a living caregiver. I will not hire another caregiver as that has not worked in the past. Hiring alternative caregivers has brought more risks to both the caregiver and my mother due to her behaviors. I will still work for my mother as I do every day, but I'll be getting paid less. I will be more burnout by this rule. This rule only allows for 8 hours of work per day. I've worked in nursing homes where CNAs and nurses are allowed to do 16-plus-hour shifts. People work 16-plus-hour shifts in multiple fields. Just because the job is inside the home doesn't mean the work isn't being done beyond 8 hours. Thankfully, my husband makes enough to where I can stay home with my mom and care for her. She's been in this state of mind since her accident when I was 4 years old, and I can't imagine placing her in a nursing home setting now. But I can see how this would be extremely negative to other Colorado families who are in similar shoes. If I didn't have that supplemental income to rely on, I would probably either have to place my mom in a long-term care facility or leave her home alone, which will result in more health and safety risk. This rule will be extremely disruptive to my mother's care. She'll be authorized for the hours, but not getting the care she requires. On the flip side, if families in similar circumstances as us hired another caregiver for those additional hours or placed their family member in a nursing home, it would be counterproductive for what IHSS was created for in the first place. IHSS is here to allow the elderly, blind, and disabled to receive care in the least restrictive environment. It focuses on community-based care instead of institutional care. It's supposed to allow patients to choose and manage their caregivers, and most of all, preserves dignity and independence. Even hiring another caregiver would
I'm
make
sorry,
our
Ms. Bell, I'm sorry, Ms. Hayes, your time is up, but thank you so much for your testimony. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Jeff Doperitz.
Hi there. My name is Jeff Dovrishta. I'm a caregiver for a disabled loved one. She has been permanently disabled for 20 years. She has Crohn's disease, multiple other conditions that she has to manage, and my ability to care for her on a day-to-day basis is what keeps both her household and my household afloat. She has a master's degree, but due to her disability, she's not able to work to earn a living. So the hours that we earn through this program are the way that her bills get paid. And by reducing those hours, that work still needs to be done, and it does nothing to alleviate my burnout as a caregiver. It's just work that I'm now not getting paid for. Yeah, and cutting the hours in this way doesn't even accomplish the stated goal, because that burden of care would then just be shifted to other programs, as other people have mentioned. So you can have cost savings in one program, but people are going to depend on Medicaid by going to the emergency room instead of getting the preventative care. They're going to depend on food stamps more. They're going to depend on other state services. So it's not even really accomplishing the goal that it's intended to. I just wanted to let everybody know that we don't have other options. That care still needs to be provided, and I'm still going to provide it. I was doing it well before I ever got paid for it. This just allows us to continue this in a somewhat predictable manner. My wife is pregnant with our first child, and by me being able to stay home as a caregiver, I'm able to be a stay-at-home parent and earn an income at the same time. So by cutting those hours, we would lose access to all of those services, and we would lose that income that we depend on. So think about the cost that that's going to have for real families, because this doesn't actually solve anything. It just shifts the burden somewhere else. Thank you.
Thanks so much for your testimony. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. Yes, we have Megan Bowser.
Megan, are you with us?
I will submit my comments via written comment and save you all 2 minutes.
Thanks so much.
Thank you, Megan. Look forward to reading those.
That was James McLaughlin.
Oh, sorry.
Mr. Sykes? Do we have
This
anyone
is
else?
Chris
lined up?
Sykes. Yes, we have Devin Gates.
Kevin, are you with us?
Here you go. Oh, hello.
Oh, Devin, sorry.
Can you hear me?
Yep, we can. Go ahead with your testimony.
Okay. Yes, I think I'm going to start off by, echoing what many people have already said today is that there is a severe shortage of providers. And from what I can see, there seems to be a pretty severe disconnect between whoever it is writing these legislations and these laws and the people living the lives that are affected by them. And, the reality of it is that I understand that, it may not be the people in this room that make those laws, but whoever needs to hear it, that's the state of the matter is the provider pool that this legislation talks about relying on and shifting the burden to does not exist. It's not there. There are no other providers. There are no outside providers. The care is provided by who needs to provide the care, and that is the live-in providers and the loved ones and the parents of the responsible, and not just the children, also the elderly, disabled, the loved ones, the caregivers. Excuse me. So furthermore, I also want to highlight the fact that there's talk about how the true burden of this legislation should be shifted on the provider agencies and the PASAs and the, established agencies. But as people have talked, take their cut before the providers get their cut. So at the end of the day, they're still going to make whole. They're still going to get their payments. They're still going to get their reparations. The ones who are truly going to get hit by this is the families. The hour cap is not just going to alleviate our burdens. Instead, it's going to establish more of a burden on us. We're still going to provide that care. We're still going to be the ones having to deal with that. We're just not going to get paid for it. And furthermore, I would like to highlight the fact that it seems, sorry, I think my phone is cutting a little bit. I don't know if you can still hear me, but it seems that there is, like other people have talked about, that when the care is cut on our side, we are still going to need that help. We're still going to need the support, and we're just going to rely on other systems to get those services. We're still going to reach out. And if there is no, where for us to reach out, the alternative to the systems that are in place is institutionalization. And the fact of the matter is, too, those institutions don't exist. There is no alternative. There is no, if this doesn't work, then we go here. If this doesn't work, we save money here. At the end of the day, it's the life and safety of our loved ones and disabled individuals at risk here.
Thank you so much, Devin. That's the end of your time. We appreciate your testimony. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We have Sharon Miller.
Aaron Miller, are you available?
Yes, can you hear me?
We can. Thanks. Go right ahead.
My name is Sharon. Oh, there's an echo. Do I need to do something?
No, I think someone had not muted their phone yet. But
Okay.
Now they have.
All right. My name is Sharon Miller, and my son is on the SLS waiver. Thank you for listening to the earlier concerns about the DD waiver cuts. My son has been on the DD waiver waitlist for almost 10 years. I'm his sole caregiver. I can't find providers, no physical therapists, no speech therapists, no occupational therapists, no mental health therapists, no nurses, no respite providers, not even doctors, even when my son develops serious health issues. All I have is occasional family help. There are no experts. I am the expert. To keep him healthy and stable, I must do my own research, implement complex care plans, and spend a great deal of money out of pocket to meet his needs. I know that part of the Medicaid waiver is I'm waiving his access to institutional care, but I didn't know it meant I'd be completely on my own once he graduated from school. Since HCPF seems insistent on targeting the DD waiver, I would be scared to accept it. even if there was an opening. However, with the term reduction, I don't think he'll ever be placed on the DD waiver, except when I become incapacitated or die. Also, with my son's high level of care, no host home would accept him at the current rates. I want to speak to the caps. Since my son qualifies for the DD waiver, the state agrees he qualifies for 24/7 care. I find the caps laughable, especially the 56-hour per week caregiver cap and the 7-hour a week cap on protective oversight. As I said, I can't find providers. How is capping my hours preventing caregiver burnout when this rule just leads to unpaid caregiving? That's a ludicrous assessment. If a member qualifies for protective oversight, 1 hour a day is not going to be enough. I don't even sleep through the night. I check on my son several times through the night, and I must intervene if he's awake. Someone without a disabled child has no idea of the physical and mental toll this kind of supervision takes on a person. If we're not going to end the DD waiver waitlist and prioritize funding for this waiver, you need a way for parents with kids on the SLS waiver to be paid for the immense amount of oversight they must provide to ensure the health and safety of their adult children. I'm running out of time, but I want to say the caps on the direct care service calculator are pretty ludicrous and require department level review, which is a waste of resources. I already have a high level review of my son's service plan annually that I have to spend months
Thank you so much
preparing
for your
and
testimony,
documenting
Ms.
for.
Sharon. I'm afraid we have to move on
Okay, thank you. I
with our
appreciate
crowded
you.
field. Of course. Mr. Sykes, do we have another speaker lined up?
This is Chris Sykes. We have Nancy Chavez.
Nancy Chavez, are you available?
Hi, can you hear me?
We can hear you well. You have 2
Oh.
minutes to provide your testimony.
Hi. Um, this policy is not just a budget cut. It's a direct threat to my child health and safety. Reducing support hours force family into extreme vulnerability and puts the life in children with disability at risk. We are not asking for a handout. We're just asking for the right to provide a specialist care for children's needs to survive. Capping these hours ignore the complexity of our children's condition and the dignity of a work as a caregiver. My child condition does not follow 40 hours per week. By limiting our support, you're leaving a vulnerable child without specialist care during critical hours, increasing a risk of emergency and hospitalization. You are not removing the only safety net we have. This is just about administrative change. It's just about the mental and physical exhaustion of family that is being told their 24/7 labor of love is no longer worth the state full support. We are a family without limits, but this rule is trying to put a cage around our survival. We are not a line item of budget. We are a family fighting to stay together. I'm just talking as a mom of a kid that is trisomy 18, that we fought a lot for him. And we hope that you guys understand that we're just moms trying to get everything for our kids. And I hope that sorry.
Take your time.
We just want the best for our kids. We fought a lot for them. I'm sorry. We just want the best for our kids. Just understand the moms that we're fighting for them. That we just need what they need. We just want to, if you could hear us as a mom, as a parent, that we're fighting for them. Not for other stuff. We just need the things for them. Because they're here because they're our miracle kids. And they need a lot of things that people don't understand. And sorry that I cry, but it's like a lot for all the families in Colorado.
Well, thank you so much for your testimony, and your emotions tell us at least as much as your words could. So thank you for that.
Sorry.
No worries. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We have Ronnie Broyles.
Hello.
Hi, we can hear you. Go ahead with your 2-minute testimony, please.
So I have a 12-year-old daughter. She is medically fragile. And since being in Colorado, we've had one nurse show up to work high on alcohol and drugs, one take the job and not show up at all. We had a nurse, these are all registered nurses. We had a registered nurse who took the job and panicked at a trach change.
Why? Because I'm mad.
I've had a registered nurse who took the job and
Mr. Broyles, I think you are on mute now.
That's me.
Mr. Sykes, is there something we need to do? Oh, there he is.
It muted for some reason. So since being in Colorado, I've had nurses show up high on alcohol and drugs, take the job and then panic on a trach change, take the job and then not show up for 6 months and call in every single day. And I think what's being lost here by the state is the idea that if we suddenly magically have nurses, which they're not out there, we can all just go back to work. A nurse cannot drive a child, a patient. So even if I had 24/7 nursing, I couldn't work a job. My daughter is home because that's where she belongs. I don't know how cutting my hours to 56 hours a week is going to solve anything, because what you're going to do is cause these parents like me who will have to go back to work to institutionalize their children who are on Medicaid at a cost to the state of about $1 to $2 million a year, where you pay me a fraction of that. So I'm not sure how this is helping anything. And two, I'm concerned because the single entry points like the Resource Exchange in El Paso County are going to take these, quote, soft caps, end quote, and then simply refuse to do any paperwork whatsoever to help parents whose children qualify for additional hours, because the Resource Exchange is more than happy to do the bare minimum possible because they were the lowest bidder for the contract, and then throw up their hands and say, well, we did our part and walk away. So what you're doing, you're going to screw families over in order to solve a crisis that doesn't actually exist. And I don't see how this is going to help anything. It's actually going to cost the state more money, because the nursing reimbursement for the state of Colorado is $52 an hour. Registered nurses in the home make $38. So I make a fair fraction of that. So how are you saving money if I have to hire a nurse, which aren't out there to begin with, to take care of my daughter, where I'm still having to work to provide her care?
I'm afraid your time is up, but we appreciate your testimony and look forward to possibly more testimony next month. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We have Andrea Fernandez.
Andrea, are you available?
I am. Can you hear me?
We can, thanks. Go ahead with your 2-minute testimony.
All right, thank you. My name is Andrea Fernandez. My daughter Leighton, who just turned 4 years old, has WT1, a rare genetic disorder that caused complete kidney failure at 5 weeks old. When Leighton nearly died on Christmas Day 2021, my husband and I were running our own small business here in Fort Collins. However, with our daughter's critical condition requiring 24-hour care, we made the excruciating decision to close the doors of our business in order to care for her full time. One of the only lights in a very dark situation was the fact that we could be compensated to meticulously administer her required care. If there had been a cap on the number of hours we were allowed to care for Leighton, as is being reviewed today, we would not have been able to maintain the income required to support our family of 5 by caring for her alone. Having a critically and potentially terminally ill child is unequivocally the most excruciating pain a parent, or I'd argue a person, can experience. I'll be completely honest, having some degree of financial stability and support from Medicaid during the most traumatic experience of a person's life has been the only true silver lining in what can otherwise be a very dark world. My husband and I are college-educated, hardworking, entrepreneurial citizens. Our family has never taken advantage of any system. Dedicating our lives and our vocation to caring for our seriously ill daughter has been the honor of a lifetime, but is also difficult beyond measure. If we were required to seek additional employment or to allow other caregivers who do not exist into our home who are less experienced or would disrupt the critical continuity of care that medically complex children depend on, it would be devastating beyond words. To be candid, there are not caregivers who are qualified or available to come into our home. Please do not allow a cap on in-home caregiver hours. Please honor the dedication and sacrifice of parents who commit their lives and livelihoods to care for the very most vulnerable. Doing so protects children like my daughter and preserves family like ours. So thank you so much for listening. I really appreciate your time.
Thank you, and thanks for your patience in waiting for this part of the meeting.
Thank you.
Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We have Chloe Weber.
Hey, can you hear me?
We can. Go ahead with your 2-minute testimony, please.
Wonderful. So my name is Dr. Chloe Weber. I'm a single mom to my son Remy, who has a very rare and complex neurological disorder called STXBP1. I'm also his full-time caregiver, not because I want to, but because there is literally nobody else. So I'm here to speak against those 56-hour caregiver cap. If this cap is implemented, my income would be cut literally by half. That is not a small adjustment. This is the difference between being able to keep my child safe, housed, and cared for at home, or being pushed into absolute crisis. This cap is not a scalpel, it is a hatchet for the families that need the support the most. This policy disproportionately impacts single parents like myself and children with the most extraordinary needs. Two-parent households, or even people who are co-parenting, may be able to divide the care and the income. Single parents cannot. There's no second shift, there's no backup caregiver. I am my son's entire village. Colorado already has a documented caregiver shortage, especially for high acuity pediatric cases. Families cannot find trained caregivers, agencies cannot staff these cases, as you have heard time and time again today. Because of that, a 56-hour cap only saves money if families cannot fill the remaining hours. That means the savings is coming from the unpaid labor and burnout, not from efficiency. Parents like me cannot just work more. School is only 172 days a year, and that's only when they're even healthy enough to attend. There's no after school, there's no summer camps. My son's never been invited to a birthday party. There's no standard childcare options. Reducing caregiver support will not save money. It will increase emergency care, hospitalizations, and institutional placements. If Colorado moves forward with this policy, high acuity pediatric cases and single parent households must be explicitly protected. Balancing the budget by destabilizing families like mine is not sustainability. It is harmful, and many of you took the same oath that I did. I'm asking you not to put the most vulnerable families in Colorado in harm's way.
Thank you so much for your testimony, Dr. Weber. Chris Sykes, do we have anyone else signed up for testimony?
This is Chris Sykes. We do. We have Rayanne Garrettson.
Hello, can you guys hear me okay?
We can. Go ahead with your 2-minute testimony, please.
My name is Rayanne, and I am the sole caregiver parent of a medically complex child who is fully dependent on me for all care needs. My daughter requires total care as she is blind, nonverbal, immune compromised, and has no awareness of danger. She receives 6 G-tube feedings per day, including a night feeding, along with constant supervision for mobility, safety, and medical monitoring. She cannot be left unattended at any time. I am here to speak in opposition of the proposed 56-hour weekly cap per caregiver. The proposal assumes that the families can simply add additional caregivers once the cap is reached for families like mine. That assumption is not realistic and not safe. I have no family in Colorado and no informal support network capable of meeting my daughter's medical needs. My child is not eligible for traditional care and is considered a liability due to her medical complexities. There are no backup options. I previously attempted to outside
to outsource providers. Unfortunately, those experiences resulted in document safety and compliance issues, including staff signing my name to hours they did not work, neglectful supervision, caregivers falling asleep while responsible for my child being left unattended in a tri-level home with stairs, being told by a caregiver she would let her sit in her own vomit rather than provide care. These are not inconveniences. These are serious safety risks. The proposed 56-hour cap would force families to rely on multiple caregivers, even when that increases the risk of neglect, medical error, or harm. It prioritizes administrative limits over the care continuity, which is essential for medically fragile individuals. I provide my daughter's care safely, consistently, and in her own home. I manage her feeding schedule, medical needs, and transportation and daily living support without placing her or others at risk. The current hours are not excessive. They are what allow my child to remain safely at home and prevent higher costs in institutional care. Reducing or capping those hours does not create new caregivers. It simply removes safe care. I respectfully urge the Medical Service Board to reject 56-hour caregiver cap, or at the minimum include a clear enforceable exemption for medically complex individuals who
I'm
rely
afraid
on
your
a
time
single
is
trusted
up, Ms.
caregiver.
Garretts, and I appreciate all your patience in waiting to testify today. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Terry Magrins Courtney.
Hi. Can you hear me okay?
We can hear you just fine. Go ahead with your
Wonderful.
2-minute testimony, please.
First, I want to thank you all. I am a parent of a medically complex child that depends 24/7. She does not use her hands. She's one of 6 in the world with a very rare form of mitochondrial disease, congenital adrenal hyperplasia, spastic quadriplegic cerebral palsy, dystonia, speech apraxia. And I just want to thank you for hearing us and listening to us. This cannot be an easy thing to hear, just such a small sample of what you have heard so far from the parents. And the caregiver cap, for me, my greatest concern is the risk of infection. She needs 24/7 care. She's immunocompromised. And having multiple people come in and out of the house places a tremendous stress. My husband and I are very cautious with making sure that she stays healthy and out of the hospital. My concern is with multiple people taking on different shifts. What does that mean? What is best for our children? What's best for our children is to keep them at home. And where does humanity lie when we make this hard of a decision? Right now, you've heard a small sample, and we haven't even scratched the surface for the amount of parents who all have a very similar story. And yet we've been given angels to live among us. Not everyone is this lucky to have the true meaning of unconditional love with a medically complex child. And for that, I pray that you all really realize that we are in the pressure cooker looking out, and you all are on the pressure cooker looking inside to see how can we make this sustainable. What does that mean when you have so many people affected? Thank you for your time.
Thank you Yes, thank you for your testimony. Chris Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Bryce Rafferty with us.
Joe?
Can you hear me?
We can hear you just fine. And Terry, if you can please put your phone on mute, we're getting some feedback. Thank you. Go ahead, Mr. Rafferty.
Wonderful. Bryce Rafferty again with CCDC. I'd just like to say that CCDC would like to thank HICPA for ending the nurse assessor program by recognizing the many problems arising in large part from the lack of a clear, robust regulatory framework informed by meaningful stakeholder engagement to ensure transparent, consistent, and uniform policies, procedures, assessment tools, and standards. The absence of adequate rules resulted in inequitable and inconsistent program administration and confusion among CMA's members and other affected stakeholders in person-centered support planning. Without centralized and unambiguous rules, complex programs requiring harmony among all affected state entities and members are neither fiscally sound nor operationally effective in serving the state's most vulnerable populations. CCDC looks forward to continued collaboration with the department to prevent future situations that cause confusion and inconsistent application of assessment processes and tools used in the support planning process, including the upcoming CFC Direct Care Services initiatives. We stand ready to be of assistance to support fair and clear implementation of future assessment processes. Thank you so much for your time.
Thank you for hanging in there and testifying. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Ashton Rinker.
Hi. I just want
Hi, we
to
can hear you just fine. Go ahead.
thank you. I just want to start off by apologizing if I become emotional. I'm just going to focus on my personal story. I feel like everyone has voiced a lot of good statistics, and I'll leave that to the professionals. But my son is 3 years old. I'm a single mother, and I have been. I found out early on he had a genetic condition, and we have spent his whole life in and out of the hospital, and I had to move from my home to find a town better suited for him so he could receive the best care. And he has a genetic syndrome where it requires him to have several surgeries throughout his life. He's had 15 just within the 3 years. And when he was born, I spent over a month in the NICU where I lost my job from the sheriff's office because I couldn't return to work. So after that, we got introduced to the program, and it's just saved our lives, honestly. I don't know where we would be without it, and I don't know where we will be if this cut does happen. He was in the hospital 2 years ago for a trach, and they said it would be over a year that he would be assigned a nurse to go home because the waiting list was so long. So I took the necessary training in the hospital so we could go home as soon as possible. We came home in 3 months, and our whole lives changed, but I made it work, and it's really not realistic for me to even have another job.
Thanks so much for your testimony. I'm afraid your time is up, but there'll be more time to testify in the future.
Thank you.
Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We have Corinne Jensen.
Hello, I'm here.
Hi, we can hear you just fine. Go ahead with your 2-minute testimony, please.
All right, thank you. Thank you for your time. First of all, I'd like to thank all the commenters and just say I stand in solidarity with all of them regarding caregiving. I am a full-time caregiver to my husband who was severely disabled by stroke 12 years ago. I've been his caregiver ever since because of his medical needs. And if a caregiver a caregiver hourly cap at 56 hours impacts both of our lives and our livelihood. Saying this is to alleviate caregiver burnout is very neglectful and is really up to the caregiver to decide, not the department, whether we are burnt out or not. And like has been said, more likely to be more burnout by trying to figure out how to fill the gaps that are created by this cap. Not to mention the extreme financial risk to us caregivers. These decisions are reckless and make no financial sense to the health and well-being of our vulnerable family members. Not to mention, this deviation in care is going to wind up costing more to Medicaid for the lack of services, and also the services that we can provide our loved ones, and causes disruption, like has also been said, to the continuity of care. I feel honored that I can be home with my husband and just need this to not be passed. Thank you.
Thank you so much for your testimony. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do. We have Tracy Anderson.
Tracy, are you with us?
I am. Thank you. My son is 23 years old next week. He's required 24-hour one-on-one medical care since the day he was born and will continue to do so until the day he dies. When he was 4, due to the nursing shortage that remains an issue to date, I went to school and earned my LPN license, and my husband earned his CNA license. This was necessary because we were not able to find nurses to care for him while we went to our full-time jobs. I became unemployable outside of the home due to his needs and his appointments. We are his sole care providers and have been for the last 17 years. He has a tracheostomy for breathing and requires all feeds via G-tube. He's nonverbal and developmentally approximately 4 to 5 years of age. I'd like to point out that by capping the PDN nursing hours to 56 hours a week, HCPF will force families to work together, providing care for each other's children and loved ones. Parents will work 8 hours for their own child and then 8 hours for the other family's child. This way, caregivers will still get their 16 hours a day, resulting in no savings to HCPF. And because of the daily interaction with the other child and caregiver, Medicaid will likely see an increase in expenditures due to illnesses and hospitalizations from cross-contamination between the two families. Why are we not asking HCPF to spread these cuts over the 92% of Medicaid recipients instead of balancing the budget by cuts to the most vulnerable 8%? What about instituting minimal copays for the 92%? In 17 years, we have never been able to staff any hours for our son outside of the 16 hours a day or 112 hours per week that I provide LPN care for. If I'm forced to go back to work, the agency would have to staff his case by an RN at a much higher rate, and that is assuming an RN can even be located for his case. The home health agency reimbursement rate for an LPN at 8 hours a day is a cut of $323.84 per day. If an RN is needed to come in and provide those hours, it would cost HCPF $428 per day. Just this example will cost HCPF $100 a day more in scheduled nursing hours, not to mention possible hospitalizations and illnesses. Please read between the lines and see that these cuts are not the answer. Thank you.
You're on mute, Barry. Sorry.
Sorry about that. Do we have anyone else left to testify on this?
This is Chris Sykes. If Amanda Swagger is online, I believe Amanda is our last individual.
I'm here. Can you
Hi,
hear me?
Go ahead with your testimony, please. We can.
Hi. Okay. So my son was born at 23 weeks and he has a trach, a ventilator, also requires G-tube feedings. He is autistic, about an age of 4. He is 8 years old. If this comes to play where the cap is 56 hours, there is no way that my family can afford to find any nursing to come into the home because there is none available. I even moved in between Pueblo and the Springs to see if I could get more nursing availability between the two counties, and I still have not yet to have one. I've had nurses show up on Valium and take out glass cabinets. I've had nurses show up drunk. I've had nurses to where they call off and know that, hey, they need us, so it doesn't matter how much time they take. If this cap is made, we will see more hospitalizations for my son because I won't be able to give him the care that he needs. And I've seen nurses in my home freeze a trach change. And had I not been there, he would not be with us today. I just don't think that the cap is what we need. We need to find a different solution.
Thanks so much for your patience and waiting to testify. Mr. Sykes, is that the end of our public testimony?
This is Chris Sykes. I apologize. We have Sarah Morgan with us.
Hello.
Hello, Ms. Morgan. Did we hear from you earlier?
Yes, about a different issue.
Okay, great. Well, go ahead. Your 2
Perfect.
minutes.
Care does not stop for medically complex individuals, including my own son who has a rare genetic condition on a hard and fast limit, and families should not be forced to have care from agency-provided strangers to increase state tax revenue. The 56-hour cap will force families to bring multiple caregivers into the home to piece together coverage. This increases risk, disrupts continuity of care, and places vulnerable members, including children and medically fragile adults, in unsafe and unstable situations. Many waiver service recipients require well over 56 hours of care due to complex medical needs such as ventilators, oxygen dependence, seizure disorders, feeding tubes, mobility impairments, or significant behavioral health needs that require constant supervision. These are not optional supports. They are the difference between remaining safely at home or experiencing preventable medical crises. When in-home supports are reduced, data consistently shows increased utilization of emergency departments, inpatient hospital stays, and institutional placements, all of which cost the state significantly more than community-based care. One hospital admission can exceed the cost of months of in-home care services. A single institutional placement can cost multiple times more than maintaining care in the home setting. While it is true that members technically have access to appeals and exception processes, those processes take time, often weeks or months. During that delay, services are reduced or unavailable, leaving families without coverage for essential care. High acuity individuals do not have the luxury of waiting while paperwork moves through an already overburdened system. Not to mention the delays this will cause due to having to redo paperwork across the state for each member receiving services already. We know these will be delayed because when the rules recently changed, it caused a documented large backup and delay in services and approval. Community First Choice was designed to prevent higher costs of care and protect member stability. A rigid hour cap does the opposite, increasing risk, increasing system strain, and ultimately increasing cost of the state. I implore the state to look at options if they're looking to generate tax revenue, to find ways to tax the income that is coming in, if that is the solution, but also to look at that other 92% of members who receive services. Thank you for your time.
Thank you so much.
Upstairs.
If you're not giving testimony, please remember to mute your phones. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. Kelly just let me know that Christina Reynolds is with us.
Christina, are you available?
Hello there. Thank you so much.
We can hear you. Go ahead with your 2-minute testimony.
Thank you so much. I know it's been a long day for you all, and I really appreciate and stand in solidarity with everyone who spoke today. You made such amazing points, and my heart is just with you all. My name is Christina Reynolds, and I am a family caregiver who would be directly impacted by the proposed 56-hour care gap. I want to share just really briefly what a proposal looks like from inside the family, not from a spreadsheet. Care needs do not pause at 56 hours. They don't become optional. They don't reorganize themselves to fit into a rule. When caregiving hours are capped, the work does not disappear. It simply shifts onto families who are already stretched thin and have found a new normal. For my family, this proposal would create instability in care, financial strain, and difficult decisions that no caregiver should have to make, whether to reduce paid work, risk gaps in care, or push towards institutional options that could cost way more and serve families less. I am concerned that with this cap, while likely well intended, could increase caregiver burnout, reduce continuity of care, and ultimately lead to higher system costs due to preventable crisis. I ask the board to consider flexibility, policies that recognize the complexity of real caregiving situations and allow families to maintain safe, consistent care at home. Please include the voices of caregivers as these decisions are made. We are not abstract stakeholders. We are the living outcomes of these policies every day. Thank you so much for your time and consideration.
Did we lose
Sorry.
Barry?
I was on mute
Oh, no,
again.
you're there, you're
I
there,
was on
sorry.
mute.
With all the issues we've had.
Is that the end of our list of testifiers?
Oh, sorry. Kelly has just let me know that we have Donna Floyd. And Donna will be our last.
All right, Donna, are you available?
Hi, I am now. Thanks.
Hi, go ahead with your 2-minute testimony, please.
Hi, my name's Donna Floyd. I'm a registered nurse, and I've been a registered nurse for over 40 years, most of which has been in the population of home health and special needs individuals, adults, and children. I'd like the board to keep in mind that this is both adults and children. There's a wide range of individuals that we're talking about with medical needs. As somebody mentioned earlier, the 16-hour per day, if it was 7 days a week, is calculated out to 112 hours a week. Agencies for years in this state have faced increasing inability to get additional RN, CNA, LPN, PCP staffing across the board, which means these families now face having to, if they can even find a second agency, have 2 agencies in their home at minimum. And again, to the parents you've heard in the special populations, this complex medical care that's being given is beyond the steps that would occur in an ICU on a regular basis. So this isn't something easily shared, as all of you know from a medical perspective. The more different parties that have to coordinate outside of their regular systems, the increased risk for collaborative error, transcription errors, and other problems. My biggest concerns here are ones that may not have been addressed yet, which is HCPF. As was alluded to earlier in terms of the RN nurse assessor did not prepare adequately and did not have these systems in place. We are once again looking at things like this. One of the rules, 520.9, says that no RN can be scheduled for more than 16 hours a day. And that includes PDN, which is billed hourly, but also long-term care, which is billed at per visit. How are they going to calculate the hours that impacts this? If they use the 2.5 hours allowed per visit or expected as a max per visit, that's not what's actually being used, and we run the risk of lower ability to provide those additional hours. We've eaten them inappropriately, or they've been calculated inappropriately. It doesn't allow for PRN visits that are necessary outside of those 16 hours by another RN or nurse to go out and see a client when something might happen that isn't necessarily emergency room or emergent activity, but is medically necessary. So these simple things are pieces. We don't know how they want us to maintain this. Remember that CMS agencies, home health agencies, also can operate separate agencies or separate entities. So they separate themselves as a single licensed entity into a sub-licensed additional agency to provide non-medical care. So we're now asking nurses we're asking that they work across these 2 entities. It doesn't say so here. It simply says the agency or provider responsibility. These are 2 separate providers. If that null and voids the 16-hour limit, there's no purpose in it. If it's expected to be a combined effort just because there happens to be a corporate owner that owns more than one agency, that doesn't go back to the individual provider. So again, these are simple operational discussions that don't seem to be addressed in the rules. And to go back to the nurse assessor equivalent problem, they're asking for approval in February to turn this around on a pinhead, not a dime. And these operational tracking methods are not in place, and these specifics have not been created yet in rule. Again, the amount of coordination between entities that families would have to do if they had to manage multiple agencies would increase dramatically the potential risk for error and medical problems. And as a manager and a long time RN in this business, I can tell you there's just not enough staff out there for this to happen on a, oh, this will encourage agencies to recruit more staff. No, HCPF, this will not. They just can't. Thank you so much for listening to these very basic problems we have.
Thank you for your testimony. Mr. Sykes, do we have anyone else signed up?
This is Chris Sykes. We do not have anybody else that we will be getting public testimony from, but anybody out there that is signing up late, I apologize. We are unfortunately losing individuals as we go forward. You can always submit written testimony to myself, Chris Sykes. I'm on the MSB public website, so my email will be on there. And certainly I will send that information along to the rule authors so that they are aware of your concerns. And to everybody that has submitted written testimony for this, all those emails will be shared with the rule authors.
Great, thanks so much. And I am assuming we're going to forego the department update.
Yes.
Dr. Martin,
Yes.
I was wondering if I could ask just one quick clarifying question of Bryce Rafferty, if he's still in.
Okay by me.
I real quick, Bryce, with your testimony, do you support the 56-hour family limit or individual agency limit? I wasn't clear from that, and if so, or if not, could you explain?
In terms of supporting or opposing the 56-hour cap or soft cap, I can't speak for CCDC on that as of right now. My point a few minutes ago was that CCDC looks forward to continued collaboration with the department to make sure that we make the best out of the assessment tools, resources, policies, and procedures available, to make sure that the person-centered support plans, which are the driver of a successful CFC state plan, are accurate and representative of the services that are needed, fiscally sound, and operationally efficient. In terms of the actual cap, I believe that is in flux in terms of case managers getting trained on the exceptions processes for exceeding those caps. And so there's a lot of things that are still in motion that prevent me from being able to give you a concrete answer to that question.
That's a very fair answer, and I apologize. I did not intend to put you on the spot. But I do appreciate your response. Thank you very much.
Absolutely.
All right, so with that, I think we will plan to reconvene in a month.
Thank you very much, Barry. You did an awesome job, sir.
Thanks.
And thanks for everyone who joined us.
Thanks, Dr. Martin. Take care. We'll see you next month.
All righty, bye-bye.